All right. So we'll spend a little bit of time on pathologies. So we got a lot of things to discuss as far as medications go. To me, that's one of the tougher pulls on this topics is just wrapping our heads around the cardiac medications because there's a bunch of them and they all have different side effects that we have to worry about. And then how they impact physical therapy can also challenge us as well. So let's go through a few pathologies first. I think most of these we've already gone over. General signs and symptoms of cardiac disease, AFib, atrial fibrillation. So that's really, really fast contractions of just the atria. What's the problem with that if the atrias are contracting really quickly but shallowly? Exactly. There's not enough blood flow, right? So we need forceful contractions to actually advance blood from one chamber to the next. If the atrias are out of sync and also contracting but not quick, they're contracting quickly but not forcefully, the blood never actually advances to the next chamber. So that's a problem. Cyanosis, we've talked about. Dyspnea, we've talked about. Edema, we've talked about. Fatigue is one that I don't think we talk about enough. Similar to dyspnea, where we're just, dyspnea is that difficulty breathing. Fatigue is I need to go take a nap. And that's one of the hallmark signs of cardiopulmonary disease is that I've got patients that, yeah, they'll go to the docs, but after they get home from the docs, they're going to need a nap for 2 hours because it just took too much out of them. So, different heart blocks, intermittent claudication, we talked about a lot, pain, palpitations, premature ventricular contractions, reduced ejection fraction. Ejection fraction norms, what are they? Talked about it last time. I think I heard something. 55 to 75. Is it 75 or 7? I think it's 75. You're right. 55. So I always think of just over half out as the low benchmark. Less than half or less than half, we're in trouble. That's where we're that heart's really not doing well. Syncope and ventricular fibrillation all can be part of it. So heart blocks, first degree electrical impulse is slow, but don't interfere with contraction. Second degree is where electrical impulses are occasionally interrupted. And the third degree impulses do not reach the ventricles, causing the heart to skip a beat. And we might be finding that when we do our pulse rate, those abnormal rhythms. We've talked about intermittent claudication specifically. Anybody know the treatment for intermittent claudication? So if we're having pain with walking at a certain intensity, it's either miles per hour or incline. If we're on a treadmill, we could change intensity with just incline. So let's say that I can walk 2 miles an hour for 5 minutes, I'm okay. But if I try for 3 miles an hour, I start experiencing that intermittent claudication. What would your treatment then be? So reduce the speed to below that intermittent claudication level, but trying to push it, right? So again, I go back to that RPE, and we want you to work hard, but we want it to be just below this uncomfortable point. And whether that's intermittent claudication or angina or, there's other things that we could think about, but yeah, that's where we want to be. And the hope is if we can exercise at that sub-symptom level for a prolonged time, then we're going to be improving the symptoms overall. So if we can do that for a few weeks, maybe now we can walk at 3 miles an hour without intermittent claudication. Then we'll try to walk 4 miles an hour, and then we'll just keep trying to progress as much as we can. Pain common, especially jaw, shoulder, chest, periscapular pain. All of those are indicative of that cardiac pain. Premature ventricular contractions, really, that's the most common disorder seen on the EKGs. Could be normal after caffeine intake, smoking, anxiety, or alcohol consumption. And those are all things that we can directly educate our patient on and add interventions for. So caffeine, we can educate our patient on on how do we reduce caffeine. I definitely don't want to hear it, but other people might have to. Smoking, we can definitely make a huge impact on, especially I know we talked briefly about motivational interviewing. I think that's definitely something that I think you guys should be looking into. I know you got a lot on your plate right now, but I think that's a tool that you can use and look into it and see if you can strengthen your skills on that because I think we have a huge opportunity to impact behavior change, and that's been shown to be the with motivational interviewing the most effective way. But anxiety, how can we reduce anxiety with our patients? We talked about some of the techniques, even with pulmonary, if we want to be very specific. Adjust breathing techniques. Tell me more. Great. Yeah, okay, so perfect. Yeah, and I think especially if we can have them focus on that diaphragmatic breathing too, I think we can always go back to this here, right? I had that analogy, and nobody here does yoga, so it fell flat. But that's the child's pose of breathing, right? So just go back to here. Just take some deep breaths. Now, I think we can do the best that we can. Some people's anxieties are such to a high degree that we can only do what we can. But again, like if we can reduce anxiety for these next 30 minutes that we work with the person, then we've done our job. And if we can teach them that breathing technique, hey, when you're feeling this, you can go back to this tool. Here's a breathing exercise, whether it's diaphragmatic breathing, box breathing, that's that 3 seconds in, 3 seconds hold, 3 seconds out, 3 seconds hold, 3 seconds in. So that's that box breathing we could teach them, or any other relaxation method. So I do think we can give an impact. And again, we're not psychologists. We're not curing their anxiety. We're not going to ask, how did your mother treat you when you were 8 years old? Right? We're not doing that. But if we can give a couple of tools that they can manage, then that's something that's really powerful. And then limiting alcohol consumption. I worked with a guy, and I saw him on Monday after I saw you guys, and he swears to me up and down, I stopped drinking, I stopped drinking. And there's 4 empty Budweiser cans in his trash that's right next to his chair. Some must have had a guest probably. So yeah, that's something that we can definitely educate and encourage our patient on. Um, None of those are easy to change as slow as caffeine intake, but none of those are easy to change. But I think sometimes all it takes is a caring professional like us just to give the right message at the right time. I think you can do that. I know it's really hard, but I've seen other people, and I see some potential in you. Sometimes it's just the right message at the right time. And just quickly, if we go back in the exercise class, we talked about a few different models of change. And my favorite model is the trans-theoretical model of change. That's where you go from pre-contemplation, I don't even know something's a problem, to contemplation, I should do something about this, setting up a plan, and then executing the plan, and then maintenance of the plan, and then changing within it. I think sometimes our job is just to get them to the next stage. So if they don't understand their caffeine intake affects their heart, well, all we have to do is tell them, and then that automatically gets them from pre-contemplation to contemplation. If they're in contemplation, oh, I know I got to quit smoking, but it's just so hard. I've tried a couple of times and I just can't do it. All right, well, they're in the contemplation phase. They know something's wrong, but they haven't created a plan to take the step of actually quitting it. So how do we get them into that plan? Again, going back to motivational interviewing. Oh, I heard you tried quitting a couple of times before. Tell me about those times. How long did it last for? What made you successful those times? Do you think any of those things could work today? What barriers do you see in place? So all of that stuff we could definitely make a big impact with. But again, I think sometimes we in the physical therapy world, we are these champions of health, and we also, I think one of the great things about this job is we get so attached to the outcome of our patient. How rewarding was it on your clinicals when you got Mrs. Johnson walking upstairs again, or your soccer athlete scored a goal on the Friday night game? Like all of that is incredibly rewarding. Um, so I think sometimes it's equally distressing when we're trying so hard for our patients and they're not doing they're not making the changes we're hoping for. But again, I think if we just reframe what is success for us is getting them that one stage closer on that theoretical model of change, then we can be really happy with our job. Because I think I can do that for just about every person. I think if someone has a plan and just hasn't started with it, I think I can give that friendly nudge to say, I think we can start this plan. So if we just take smaller bites of that elephant, I think we can be successful. But if you try to eat the whole elephant at once, you're going to be pretty disappointed. So that's one thing that I've changed in my career. I know early on I used to get so frustrated. This guy's ripping butts right before on his, like, you see him park his car, he rips a butt out on his walk into the parking lot, and then he comes in for physical therapy. He's had 2 heart attacks. Why is he? I used to get so disappointed in myself and in him. But I think, yeah, it's just about getting them that next layer of change, that one step closer. So that ejection fraction we've talked about a lot. I don't think we have to spend too much more time with it. Syncope, VFib, we've talked about a little bit. So general treatment, dietary modification, reduce total fat intake, intake of saturated fats, salt intake. What's great, I think that we are not nutritionists, so we are not giving exact diets to patients, but I think we can champion what a healthy diet is. And if they already have prescription, there's plenty of times that I'll walk into patients' homes and they'll have a folder from their hospital stay, and it somewhere buried in the 40 pages of documents that they have is a skeleton of what a healthy, oh, you came in for diabetes, so here's the foods to stay away from. Here's the foods to add more of. So, all right, I can take that and I can champion that for them, and I can help translate what that means for them. Same thing for, urinary tract infections. Here's some prevention foods and drinks for that. Cardiac, here's what to stay away from. Here's what not to. I think just teaching somebody how to read a food label can be hugely impactful. Also, the American Heart Association has dietary guidelines, so we don't even have to say, oh, reduce fat intake. Like, we can just go to the American Heart Association, print out their dietary guidelines, and say this would be good for you. There's nothing wrong with that for us. General weight reduction can also help. I had a really tough conversation with a guy. It wasn't this past summer, it was a summer ago, so it was, a year and a half ago at least. He was about 400 pounds and he had an arthritic knee, and that's what I was there for, that arthritic knee. And, at the end of it was about 4 or 5 weeks I worked with him until he was back to where he needed to be. At the end of it, I just was able to sit with him and said, I need to have a tough conversation with you. This arthritic knee isn't going anywhere. And at your size, I'm going to keep coming to see you might be once every 3 years. It might be, once every 3 years for the next 6 years, but then I'm going to see you every 6 months maybe, because this thing is going to continue to deteriorate. Our osteoarthritis is a progressive condition. At your size, it's probably going to deteriorate faster than if you weighed less. And I also said, no one's going to give you a knee replacement at your size. Oh yeah, I've already talked about that. I've already been told no by 2 different surgeons. Okay. So I love you, and if this next time this knee goes on you, I hope you call me, because I really enjoy being with you, and it's a pleasure being here in your home. You're a great guy, and I'd like to see the best of you. But if you want an ultimate solution, you got to lose about 100 pounds, and then you're at least within shot of having a surgery. And who knows, if you dropped 100 pounds, maybe the knee wouldn't hurt you so much. Like, I don't know. Like, osteoarthritis is a funny condition. I've had some people lose 40 pounds and their musculoskeletal problems disappear. I've also had people lose more than 40 pounds and their musculoskeletal problems never change. So it's not a definite, but man, I've seen it happen. So those are tough conversations that we shouldn't shy away from. And again, I think I've said this a handful of times over the last few days. The power in physical therapy is in the relationships and the trust that we get with our patients. So having those conversations just might hit a little bit more meaningful than when their general practitioner says, you're overweight, here's a pamphlet on how to reduce weight. So I don't shy away from those, especially if our patients have cardiac disorders that are 100% going to be impacted by some of these things. Regular exercise program. I think I have it later on. What's the phrase? Champions of a active life, or we'll find it later on. But what is regular exercise program? And I think for a lot of our patients, how many patients when you guys were on clinicals were just afraid to exercise? Did every single person find some patient who was afraid to exercise? Yeah. And it might be I'm afraid to exercise because this knee hurts so bad, or I've never enjoyed exercising. I don't want to do it at all. I know we've all seen that. So finding solutions to that, because I think exercise, when someone walks by CrossFit and they can easily say, well, I don't want to do that. All right, but that's not the only thing that exercise is. Exercise could be a million different things. So as much as we like to make fun of pickleball, pickleball is freaking awesome because you get to get out there and move around for a while. And that, yeah, sure, the sound of those balls sound pretty annoying and a little silly, but man, that is so awesome when I drive by a park and I hear those dunk 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 dunk. It makes me so happy to know there's a bunch of people that are being active. But my son's playing Pokemon Go. What a great way to move around. There's a million different video games that have virtual reality interface now. Altered reality? I forget what, but man, Pokemon Go is great because you go walk around the park, finding Pokemon's playing a game. Like, that's awesome. If you can do that, that's way better than sitting on your couch playing Pokemon. So there's definite ways that we can encourage our patients and we can educate them on what exercise is and how to not be afraid of it. Drug therapies, making sure we're compliant with our drugs can also be a huge problem. There's a lot of different barriers there. We're going to get into drugs later too. So here's a handful of cardiac medications that we will be needing to know. I want to see, I think I put this in a few different places. Yeah. We're going to come back to the medications. We're going to spend a little bit more time. I just want to go through a few disorders and then we'll do some medications and we'll have a bunch of time on medications. So, coronary artery disease, sometimes known as ischemic heart disease or acute coronary syndrome. I've always heard as CAD, coronary artery disease. The category includes conditions like angina or myocardial infarction. It's the leading cause of death in the United States, 365 deaths per year, 27.6. This number's higher now. People living with CAD in the United States. Men develop symptoms at an earlier age. Women tend to have more complications from this. So men battle it longer, but women battle the severity. So again, coronary artery disease is narrowing of the coronary arteries because of this gradual plaque buildup, which cause an abnormal blood flow, abnormal and reduced blood flow. So how does somebody get that plaque buildup? Diet. Diet's the number one way, although there's definitely a correlation between smoking and also alcohol consumption. Smoking, why do you think smokers, so why diet first?
Based on just what certain foods they have, like maybe a lot of like fat in it or something your body can't process at the time and it just flows around.
Yeah. Yeah, so diet intake of higher cholesterol foods will create cholesterol in the arteries, and the more cholesterol will mean they land somewhere. The LDL cholesterols are the stickier and unhealthy ones. HDLs are the healthier ones. We'll look at that at some point today. All right, so diet makes sense. Why smoking? Why does smoking increase the risk of CAD and PVD, peripheral vascular disease?
That you're inhaling from the smoke going through kind of like oxygen that goes to the like right to the blood, so wouldn't that just kind of like Is that similar?
So yeah, so what happens is high blood pressure can do this too. The smoke and all of the different chemicals that are in that smoke damage the walls of the arteries. So what happens when these plaques are floating around, these little, fat plaques are floating around, the inner walls of these arteries are pretty slick. They're, but when they become damaged, now there's a fissure that's now got a sticky spot. That sticky spot creates an opportunity for these flaques that are floating around to grab and just hold on to land and then get stuck to. And then once a little piece gets stuck there, then more and more plaques can grow onto that plaque and then it grows from there. So that's why smoking, it damages the blood vessels. Same thing for high blood pressure. Chronic high blood pressure, we're constantly stressing those arteries, which are going to create that little damage too. And we'll get into it later too, but I cannot stress this enough. I think a lot of what we're covering this last week and this week is your patient has this heart attack. What are we going to do for them after their heart attack? And that's a great way to do it. A great way to think of it because we're definitely going to have plenty of patients post heart attack. But I think what's going to happen much more in my career in the home care world, again, I've had patients with heart transplants. I've had patients with pulmonary COPD. That's the number one reason I'm in there is because of that. All of, gosh, if it's not all, it's it's well over 90%. I'd have to take a guess. I know it's not 100%, but gosh, it's close. Almost all of my patients have a condition that I'm seeing them for: knee replacement, fall risk, came in and out of the hospital for a UTI, whatever it might be. And almost all of them have a cardiovascular comorbidity, as little as high blood pressure. So I think when we have, again, CAD leading cause of death in the United States, three biggest factors: diet, smoking, and alcohol consumption, and then high blood pressure are the three biggest risk factors. All of my patients could use a little bit of education on how do we maintain healthy blood pressure? What can we do about reducing our cholesterol and through diet or medications? So I think there's an opportunity for all of us to impact as many patients. When you guys were out in the clinicals, how many of your patients did you notice had a history of high blood pressure, or did you not even look at that? Good amount? Yeah. Yeah. The midday crowd. The early morning is usually a little bit younger, got to get off to work, and then the afternoon crowd is usually the older, just getting out of work or athletes. That middle of the day crowd, though, that's our comorbidity crowd. So on your next clinicals, you can to keep an eye out for that. I know half of you are going to inpatients, so you'll be able to see plenty of direct. Oh, they had a heart attack last week. You're all going to see some of that. But even if those that are on going to outpatients, take a glance and start just a little rough estimate in your head. What percentage of patients do I see that have a comorbidity of something cardiopulmonary? It's extremely high. Angina, so that's chest pain brought on because of activity. So, all right, let's think of activities. So this happens usually older adults. It's usually this time of year and in the winter. I've been sedentary all spring and summer, but now all of a sudden I got to rake the leaves. In a couple months, all of a sudden I gotta shovel the walkway. So it's that slight increase in activity. So what happens? So as we increase activity, our heart rate should increase as well because we have more of a demand for oxygen consumption for all of our working muscles and systems, including the heart itself, right? So we have to remember the first thing the heart feeds is itself. The first branches off the artery go right back into the heart. So the heart tissue, the myocardia has blood supply to continue doing its job. Well, if I increase the demand, so the heart rate starts beating faster, that increases the demand. The heart tissue itself needs more oxygen itself. So if these arteries are narrowed and can't deliver the blood to keep up, supply can't increase as the demand increase, that's where we're going to start having ischemia, and that's where we're at risk of tissue death. So that ischemia causes the it's almost like a fake heart attack. Chest pain, jaw pain, left shoulder pain, usually left jaw pain. Feels like an elephant sitting on your chest, profuse sweating. All of that are signs and symptoms. So typically what happens is somebody just, hey, Marge, call 911, right? So we call 911 right away. I'm having a heart attack. And then by the time the ambulance gets there, well, after 5 minutes of just sitting down, they no longer have any symptoms, and now they don't want to go to the hospital. So that's the classic example. Sometimes as the anxiety and fear works up, that can last a lot longer too. So, but sometimes it's in the ambulance on the way to the hospital is when those symptoms subside, and they say, "Oh, turn around, I feel fine now." No, we're going. So atherosclerosis is the number one mechanism of this. Other things can happen, but that's the number one. So again, shoveling snow or leaves are the most common events around here. But other things can. Having to go upstairs all of a sudden one day. There's just one extra piece of plaque that stuck that made that narrow artery just one hair just too small, and now we're at the threshold where we that can't keep up. But also, emotional responses, getting angry, getting in a fight with the loved one, and traffic, getting road rage in traffic, and any of that stuff that might increase this heart rate could be it. So angina could be stable, which occurs at a predictable level of exertion. We talked about that with our stress test, right? So didn't we talk about how stress tests can sometimes predict when angina happens? Anybody remember the math formula, what that was called when they can take, oh, angina starts to happen at this heart rate multiplied by this blood pressure. That's going to give us this number. Anybody remember what that was? It was systolic blood pressure times heart rate was the formula for it. Anybody know what that term was? Got a lot of studying to do before Friday, huh? That was double product, or was it rate pressure product? I remember as double product, but I think the newer term is rate pressure product. So it's really nice if it's stable, because then we can, just like with what's our treatment program with somebody with stable angina. When they reach this certain number on the double product, they're going to get angina. What do we do? Stay below it. Challenge them, but stay below that. Yeah, just like with intermittent claudication of the legs. It's the exact same disease process. It's the exact same symptoms, except one is in the calves, the other's in the heart, and the heart, because of its importance, kind of goes Chicken Little on us, and it creates all these other problems and all this. It's just more exaggerated. But yeah, the treatment's the exact same. Talk to your patients on lifestyle modification, and then exercise below the level of, in this case, angina, below the level of symptoms. But let's challenge our patients to see if we can get that threshold higher and higher. Or what's more troublesome is the unstable angina. That's where we can't predict. That's where it might occur with less exertion. It could occur at rest. It could be spontaneous. That's a lot more concerning and a lot more troublesome. And that person needs significant cardiac interventions beyond just physical therapy. So the signs and symptoms we've described, including pallor. What's pallor? Pale skin, diaphoresis, excessive sweating, good. Nausea. So the first thing that once they're diagnosed with angina, and actually the first thing that the EMTs do when they show up and somebody's got this, they give vasodilator. Nitroglycerin is the vasodilator of choice. So when we get into more medications, we're going to be making sure that we learn about each of these medications, what they do. But nitroglycerin is the number one thing for them. So once that angina symptoms start coming on, we instruct this person to take, it's a sublingual, so they just put it underneath their tongue. After 3 minutes, if they're not getting relief, they can do another one. So it's a extreme vasodilator. And if you think of, if we go back to the pictures of these narrowed arteries, well, if we take this artery that's narrowed, well, yeah, I can't do anything with the plaque right now, but let's just let's just dilate that coronary artery as much as we can. That way more blood flow can pass through. So that's the power of those nitroglycerin. What I'll tell you is if someone has a diagnosis of angina in the physical therapy world, and has anybody seen a patient who's diagnosed with angina? Do you remember that in your clinicals? I bet you did. You might not have even seen it. So maybe you didn't. But I will tell you, if your patient has history of angina, you need to know, where's that nitroglycerin? Is it on you right now? So just like, do we have sugar when we're working with our diabetic patient, our patients with diabetes? Do we have our inhalers for patients who have asthma? This is just as, if not more important than that. We cannot do physical therapy if you do not have your nitroglycerin on you. Where is it? Put it in. All right, put it over there. We'll that way we know it's there. So incredibly important. Have you? This might have been when at your work more than. Have you had to see any patients that have needed nitro during their stay? No. Oh wow. Yeah, yeah, but I'm surprised that you didn't see any. I've had patients that have needed. Yeah. I had one guy. Oh, you guys remember the guy with a tack in his foot that he didn't know was there? I told you that story. So I was working with that guy. Surprise, surprise, this happened to him. So I was sitting there, and he pulls something out, and he takes something, and then he does another, and he does a third, and I say, like, what are you taking? Because he was like, it was in his like hand and pocket down here. And he goes, "Oh, it's nitro. I have extreme chest pain right now." I go, "You just took 3 doses of nitro? Like, this is a that's a it's a major piece of information I need here, man." So, not the greatest at taking care of himself. So anyway, so really, really important for us to make sure if somebody has a history of angina, really, if they've been prescribed nitro at all, we need to make sure that it's it. Most commonly, it's because of nitro. Could also be a history of heart attack too. Other things that we might have to do, extreme avoiding triggers like hot and cold, or moving right from hot to cold is usually a triggering event. Using RPE dyspnea scales, strong emotional incidents. This is another one where we might be able to employ some of our breathing techniques just to help manage our emotions. Anti-anxiety medications and other stress reduction activities. So, closely monitored exercise program is what we're going to prescribe below the level, below the threshold of this angina if it's stable. And really only exercise if those vasodilators, that nitro is on hand. That's the big thing we've got to do. Myocardial infarction, also known as a heart attack. Now there's tissue death from ischemia. So here with angina, there's no tissue death because it was relieved by rest, and we didn't venture into that. Once there's tissue death, now it's now a myocardial infarction. When we looked at EKGs last time, how would we see a heart attack? It's not the only ways, but the major ways that we in the physical therapy world would recognize signs of a heart attack based on the EKG. Does anybody remember that? So the ST segment or the T wave itself. So what happens if it's a smaller heart attack? What happens? It depresses. And if it's a major heart attack, it'll elevate. And then a smaller or a previous heart attack, there might be something with the T wave. Anybody remember what that happens with a T wave? Yeah, so just because it goes down doesn't mean it's depolarizing. It's actually still repolarizing there. But yeah, we could see an inverted T wave on the EKG rather than in the positive, it would be in the negative. So good. So there are for those who survive heart attacks, there's a great risk of a second heart attack. So being able to, once you have that heart attack, our job, there's a major piece of our job is talking about diet and lifestyle modifications to prevent that second heart attack. Congestive heart failure is also really, really common. So congestive heart failure is this heart tissue isn't strong enough to eject enough blood. We talked about that, especially if we can measure that with reduced ejection fraction, if it's in the left side of the heart. Their right side of the heart is a little bit trickier, but with left side of the heart, we can see it right away with the reduced ejection fraction. So that makes sense why a myocardial infarction could lead to congestive heart failure because we just damaged a bunch of heart tissue. It's not going to work. So, of course, that section of the heart is weaker, and a weaker heart equals more congestion, less blood flow pumping. Um, so there's a few different types of myocardial infarctions due to their cause. I don't see these most of the time, but it's nice textbook knowledge for us. It might show up on Friday and it might show up on your licensure exam. So type 1 due to atherosclerosis and blockage of major arteries. Type 2, there's a mismatch of oxygen supply and demand for reasons other than arterial blockage. This is a little weird. Type 3 only includes fatal MIs, so we don't see a lot of those. That's, and types 4 and 5 are attributed to heart attacks as a result of medical procedures like angioplasty or stents. So that's where, okay, this person's in a lot of trouble. They need life-saving surgery. During surgery, they had a heart attack. So we do see those, and those are unfortunate. So type 1s are the ones that we really can have a great chance at reducing, but also we're going to be treating and educating after. So type 1 could happen because of a thrombus obstructing the artery. Vasospasm occurred in a partially blocked artery, which creates a total blockage. And then part of a thrombus breaks off from a DVT typically, and then lodges itself in the smaller coronary artery. That's why we're extremely cautious with treatment and management of DVTs. So we want to prevent DVTs because we want to make sure that they don't develop. But once they have a DVT, we have to be extremely cautious in how we manage them. Yeah. ST depression, small heart attack, or previous MI. Yeah, yeah. Um, so there's a few different ways to treat this. So actually, other ways to diagnose a heart attack is with our blood enzymes. So we can look at our blood enzymes, especially our CK numbers, to determine if this has been a heart attack or not. And that's something they start looking at right in the ambulance. So if blood supply can be restored within 20 to 30 minutes, irreversible damage could be avoided. So, man, if we can get to this quickly, that's fantastic. And that's why they give the second there's questions of heart, they're giving nitro right in the ambulance to try to make sure let's vasodilate this and give this heart as much blood supply as we possibly can, because we could be reducing the irreversible damage risk. Collateral circulation of the heart reduces the size and infarctive injuries. So if we go back to our heart anatomy, this is an okay picture here. So, we have our main arteries, but there's also collateral arteries where they branch off and connect with each other in various ways. If we have a lot of those collateral connections, then a little blockage. That's why David Letterman was able to not have any symptoms and needed a cabbage times 5, because he had so much collateral circulation that blood was able to go around these blockages. So it's, I think, oh, you guys didn't start learning the circle of Willis and brain blood supply, right? You'll do that in next semester on, it's an amazing structure and how much collateral circulation there is to try to make sure that there isn't a blockage if it does happen. It's as little damage as possible. But that collateral circulation is why some people can live with massive coronary artery disease and not have any symptoms. I had a guy, he played golf once a week at least. And every time he played golf, he'd have heartburn for the rest of the day and into the next morning. And he always blamed it on, the beer and the hot dog. And I was like, well, why'd you keep eating the hot dog then if you thought it was, but he kept doing it. And he went for a regular checkup and they said, oh boy, you have what do you he needed a cabbage times 3. He had 3 different arteries that were over 90% occluded. And it was just that level of activity, and that heartburn was his angina sign of that. But he had such strong collateral circulation that it never got to the beyond that heartburn type level. So pretty incredible. So if the blood supply is not returned to the heart tissue, it'll eventually become fibrotic, which now it's not going to expand and contract. It's just going to be a really stiff vessel that's not going to help us deliver blood a lot. So signs and symptoms we've talked about frequently. I don't feel like we need to go into that more. I will say for most of the time, men have classic symptoms: left shoulder, jaw, profuse sweating. Women's symptoms are a little bit more subtle, generally, not always, but generally. And that's where we have those silent heart attacks. So this guy that I just talked about would be a good example of that repeat indigestion type feeling was actually a cardiac symptom. But some people just have prolonged mid-scapular pain, and they might actually be coming to physical therapy saying, I don't know. And we might say, it's rhomboid, it's mid-trap, maybe what did you pull? But sometimes that's just heart attack. It's referred pain from the heart damage. So we could do EKGs, blood enzymes, arterial blood gases, pulmonary artery pressure measurements, all for diagnosis. So sudden death shortly after a heart attack occurs in about 25% of cases due to cardiac dysrhythmia, and then the heart can no longer function. Cocaine users may suffer from fatal heart attacks due to the drug interfering with cardiac construction, as well as causing vasospasm and occlusion too. I had one patient. I've had more than one patient, but I have one patient who was a heavy. He was a cocaine user, and I can remember the reason I saw him because he was very honest with me, which was refreshing. But he was high on coke and drunk, and he jumped off a cliff. And he said it was to impress the women he was with. And I mean, that's surefire way to impress women is by jumping off cliffs. And shattered both of his calcaneus, which I mean, for that, like, kind of got off easy here, man. So that was the one. Like, that was a fun story to be thinking of. Yeah, Josh, I was out of my mind on coke and booze, and yeah, that was an interesting first visit. Oh, okay. Tell me more about your pain. So cardiogenic shock could occur if the pumping ability of the left ventricle is severely impaired. Congestive heart failure is really common, like we talked about. Could happen years after myocardial infarction. So less frequent complications occur: rupture of necrotic heart tissue, typically within a week after the heart attack. Thromboembolism might result, which now it can travel somewhere else or impact the heart in another way. So life-saving treatments initially: vasodilator like nitro immediately, oxygen, trying to keep the patient calm as much as we can, anticoagulants, medication, external shock to reduce, life-saving stuff. Cabbage or other procedures might be performed to restore blood flow. Patient is likely going to be on at least a low dose of aspirin for blood thinning effects. I should edit that for it's technically antiplatelet effects. To prevent future heart attacks. For us here, cardiac rehab includes inpatient, outpatient, and then maintenance phases. We're going to focus mostly on the first two phases. The maintenance phase is as the patient can be community exerciser. So we'll look at that. Other things that are going to include dietary modification, stress reduction techniques, a schedule to return to normal activities like stairs, work, sexual activities are all established. So we have to make sure we understand we're going to be seeing plenty of patients post heart attack. You will see some in your career. And I bet you in your next two rotations, because everyone's going to have some time in either a SNF or a hospital in the next two rotations, you're going to be seeing some. How many people would you say are admitted to your SNF after a heart attack? Oh, really? Almost. Geez, you have a big cardiovascular. Yeah, yeah, yeah. So there's definitely going to be some, at least in 12 of your next 12 weeks. At some point, you're going to be seeing them. But we're also going to have plenty of patients with heart attacks as a past medical history. Yeah, they had their knee replaced last week, but they had a heart attack 7 years ago. So we have to be aware of that. And again, if somebody had a heart attack in the past, they have a greater risk for heart attack in the future, also congestive heart failure. So we should be doing cardiovascular screening on those patients and talking about what is their status of their cardiovascular system. How is your diet been? Are you smoking? All of those things are crucially important for those patients. Although, yeah, the knee matters, but I think I think too often we skip past, oh, history of heart attack. That must have sucked then. No, that's a thing right now that we should be talking about too. Prognosis depends on size and location of infarction. Mortality rate in the first year is 30 to 40%. So roughly, 40% of people after a heart attack will die within a year. So it is not a small thing. Cardiac dysrhythmias or just arrhythmias, deviations from normal cardiac rate, either because of damage to the heart's conduction system or other things like electrolyte imbalances, caffeine intake, drug toxicity, stress. So rapid heart rate prevents adequate filling, which reduces cardiac output. Slower heart rate means, yeah, the heart vessels are filling, but it's not actually being injected into our system to be used by the body. So either one isn't great. Here's a handful of types of cardiac dysrhythmias you should be aware of. Brady and tachy, we already know. Atrial flutter, known as, is defined by a rate of 160 to 350 beats per minute. Yikes, that is cooking. But I think we can also just imagine if it's contracting that fast, it also means it's not contracting with a deep contraction, right? Which means that the blood can never fill the ventricle like it's supposed to, and it also, or atria like it's supposed to, but it also isn't going to eject any blood either. So real problem. Fibrillation is a rate over 300 or uncoordinated muscle contractions. PVCs, we talked about, premature ventricular contractions. A bundle branch blocked, which will have a wide QRS wave we could see. Again, I think for the EKGs, The ST segments and the inverted T wave are the major things that you guys need to know. That if what is the number one thing, yeah, that's the number one thing. There are plenty of others we could learn. We just don't have time for. But if it's it's a wide QRS complex. It could be a bundle branch block. First degree heart block, delayed conduction of the AV node with prolonged PR intervals. Secondary heart block, delayed conduction of the AV node, gradually increasing the PR interval until a contraction is missed. And then total heart block is no conduction of the AV node. Ventricles contract slowly and independent of atrial contraction. So for those people, we're going to have marked decrease in output causing syncope. So lots of different medications. That's the number one thing that we're going to be looking at is a lot of medications. Again, we're going to dive into medications in a little bit. But there could be there's definitely some side effects to those medications we'll look at in a little bit as well. They're effective in many cases, but sometimes we also require a pacemaker, so the pacemaker can be implanted. The pacemakers, I know we talked about it briefly. It looks like it's a little bit smaller than an index card. It's maybe about half the size of an index card. And you can see it's just underneath their skin. It's just this little kind of squarish thing underneath their skin, right on the superficial part of the skin. I bet you've seen those. Has anybody else seen a pacemaker? Yeah, they're just a little square bump right here. I had a buddy just get one, and he's doing fine. But yeah, it's just that superficial. It looks like it's just like an odd bit of swelling, odd square swelling. It looks like. I did have a guy who his pacemaker got his pacemaker wire got infected and they needed to remove the pacemaker. Then he needs to have an external pacemaker. And it was it's very similar to an LVAD device, which got a big like a vest type thing. And he's got battery packs and other things. And he's got it beeping all the time. And he says he can feel it going off on him. It's wild. So anyway, so this pacemakers for antiarrhythmias. So the big thing we have to do for cardiac dysrhythmias is if they have a pacemaker, we need to make a note of it because now that is a contraindication for some of our favorite modalities like all e-stims. What else? Diathermy. What else is a contraindication? Pacemakers a contraindication for? Those are the big ones off the top of my head. But anything else? Anything electrical would be contraindicated. I know diathermy too. We could also maybe with our antiarrhythmia drugs now, and especially if they have a pacemaker, definitely we're not going to be able to use our heart rate as a gauge for success for our exercise intensity. So again, RPE is something we should be using. So pulse ox can also be really important for measuring. Now, what's wild about people with dysrhythmias, there are some abnormal rhythms that are benign and not to be worried about, and that won't be medicated and won't have interventions, and we'll just monitor closely. Manual readings of heart rate is far superior than the pulse ox readings of the heart rate, because especially if we're skipping or if we have a double beat that's benign, cardiologist isn't worried about it, the readings on those pulse oxes go bananas with somebody with poor rhythm. So manual readings of pulse rate is crucial. All right, I've been talking for too long. Let's take a quick 10 minutes, and then we'll tackle some congestive heart failure next. Let's take 10, okay? All right, we'll briefly look at congestive heart failure. We've gone over congestive heart failure quite a lot. I feel like in our time together, so we'll truncate this a little bit. So just remember, congestive heart failure is where the heart muscle is too weak to advance the blood. Usually obviously we just saw how heart attacks could create congestive heart failure in the future because that tissue can no longer expand and contract and do its job like it needs to. There are other ways that we can get congestive heart failure as well. We'll look at that in a little bit. But the thing to remember is the heart is too weak to advance blood, so blood doesn't advance where it needs to. So it can either stay in the heart, which creates an overstretching effect of the heart, which makes it weaker and weaker over time. Or most of the time, what we see is we see either the fluid pooling in the lungs. So if it's left-sided heart failure, it pools in the lungs. If it's right-sided heart failure, it pools in the body. And when you see grandma or grandpa, if we go to the casino and especially in the midday crowd, when they skip coming to physical therapy, they go to the casino instead. If we walk by the slot machines, we'll see plenty of congestive heart failure. And we look at those legs, they're just going to be waterlogged legs. So coronary artery disease is the number one mechanism for creation of the number one risk factor and cause of congestive heart failure. There's others. Pulmonary disease could cause right-sided heart failure. So if the lungs aren't working and doing their jobs as well, it can impact the heart. So, prolonged lung disorders could cause heart failure as well, but starting at the right side. So there's a lot of signs and symptoms. This one down here, bendopenia, I love that one. I learned about this one as I was preparing this. This is a newer sign that's increased shortness of breath when bending forward, mean onset of time 8 seconds. So when I was reading this, I thought, oh, first of all, that's a fun word, bendopenia. And then also like, oh, that's really interesting. And I guess it makes sense how when we're bending forward, now we're fighting gravity in a lot of different ways. In a weak heart, now changing positions, I could see how that could create some shortness of breath. And I think the function of it is when we're tying our shoes. If we're tying our shoes and then we go and we get shortness of breath with that. So pretty interesting to think of. So left-sided heart failure. Left-sided heart failure is with reduced ejection fraction, and that's where we're going to get a lot of lung signs and symptoms. So dyspnea, orthopnea, cough, sleeping with the head with lots of pillows or in a recliner. The term you might be seeing is HFrEF, heart failure with reduced ejection fraction. So if you see HFrEF, it's the reduced ejection fraction is where we're saying. Where does the ejection fraction come from? Left side. So we know if we're reducing the ejection fraction, we know it's the left side. Right side of the heart, if it's failing, if it's heart failure, is again heart failure without reduced ejection fraction, or also known as preserved ejection fraction. So HFpEF is the newer name for that. I started learning these a handful of years ago, HFrEF versus HFpEF. And it was in an academic setting. I think it was a continuing ed course. I think that's much more, I don't see it on medical documentation yet. I see congestive heart failure. I might also see ejection fraction, but I don't see things labeled as HFrEF or HFpEF yet. But in the literature, when we go to research in our textbooks and in our journals, those are defined as HFrEF and HFpEF. So I think it's definitely some more of an academic term than it is a clinical, what I see used in the clinic, but it might change over the next few years. So somebody with HFpEF, dependent edema, lower extremities, buttocks, abdomen, could be digestive tract disturbances if the abdomen is edematous. So could have an increase in pressure in superior vena cava, flush face, descending neck veins, headache. That requires immediate treatment to prevent brain damage. There's poor perfusion to the brain. So I think these pictures are actually really nice way to see the differences between the right-sided versus the left-sided heart failure. So treatment includes, well, if there's an underlying cause, let's work on that. But also, let's reduce workload of the heart. So ways we can do that is reducing fatigue and stress. There's other ways we can do that with medications we'll look at later. Diet changes definitely, especially avoiding salty intake, because wherever salt goes, water will follow. So if we have increased salt in our diets, these people will retain even more water. And man, if they retain more water, their heart can't pump that excess fluid, and we've got a major problem on our hands. Also, prophylactic measures like encouraging flu shots or other respiratory conditions or other vaccinations like the pneumonia vax. The couple of main things we have to remember for treatment of congestive heart failure is we have to be extremely cautious on how we manage that excess load, that excess edema. What we can't do, if we go back to these pictures, if we look at Aunt Nancy over here with the really, really swollen legs and swollen abdomen, that's all that edema. Gravity's pulling that there. What we can't do is just go grab those legs and say, oh, don't worry, I'll get rid of this swelling and do a bunch of aggressive massage techniques and elevate the legs and get the fluid out of there. Because if we do that, where's the fluid going to go? Back to the heart. What can't handle all this excess fluid? The heart. So if we do that, we could be sending the person right to the hospital. So we really rely on our diuretics to get rid of the excess water, and really, really strict diet. We are coming up on congestive heart failure season, the holiday season. Oh, I love the stuffing that I made, and I'm gonna have some. Like we can set our watches to it. We can set our calendars to it. 7 days after Thanksgiving, 7 days after Christmas, and any other holiday like that, I know I will be seeing someone with congestive heart failure 7 days after those two holidays, because somebody's going to say, I'll have just a little bit more, or no, give me the real gravy, not the reduced salt one, or anything like that. We let one meal or typically over the holidays. The tough thing about the holidays is we have a lot of those kind of events all in a short period of time. So yeah, this excess salt intake definitely will create. I will 100% be seeing people with exacerbations of congestive heart failure after the holidays. Set your watch to it. So we have to be really careful with that. Energy conservation techniques are something we're going to be teaching to our patients, working on functional endurance, gait training, assisted device training if they need it. So we have 4 different stages in our textbook. On our textbook, O'Sullivan, there's a really nice diagram. If you like diagrams like I do, then you can look at that. Let's see, 441 I said. So I feel like diagrams like that, it's all color-coded into these different stages and classes. So feel free to glance at that. I think sometimes that picture makes things look really nice and we can understand things a little bit better. But 4 different stages of heart failure. Stage A is we have risk factors. We don't have any impairments yet, but we have risk factors for it. And man, if we can find someone who has risk factors of heart failure, if we can get them to turn their course around, we could be significantly, not only could we be saving their life, but we could also be maintaining their quality of life. Because somebody who has heart failure, the quality of life plummets. So definitely some things that we can work on in the prevention world. Stage B has structural heart disease, strongly associated with development of heart failure, but no signs and symptoms of heart failure yet. C, now we have symptoms of heart failure. And D, we have advanced structural disease with symptoms at rest despite medical therapy. So man, if we can capture people at A and B, we would really saving their life, not only again, like their actual life and years on their life, but also just the quality of life as well. Heart failure also has 4 different classes describing the functions. So class 1 is no limitations in physical activity. Class 2, slight limitation in physical activity, no symptoms at rest. Class 3, marked limitation in physical activity, but comfortable at rest. And stage 4 is now unable to perform any activity without symptoms, also some symptoms at rest. So class 1 through 4 just describes the severity of the symptoms and how they could impact somebody. Most of the time I see patients in C and D with, most of the time class 3 and 4, sometimes class 2s if we get lucky. Yeah, I usually see the worse off people. Two major valve disorders, either stenosis or incompetence. So stenosis, there's not enough blood flowing through the valves. Incompetence is there's regurgitation. So instead of those valves preventing backflow, they're allowing backflow. So now the blood's not advancing through each chamber like it's supposed to. It's kind of sloshing back and forth, which the downstream effect is my body doesn't get enough oxygenated blood. So there's definitely surgical techniques. There's mechanical or animal valve replacements. I just read someone in Mass General just had, so pig heart valves have been used. I just read someone, was it a full kidney? I think it was a kidney. Somebody just got a pig kidney implanted. He's had it for 270 days or something like that. Yeah, pretty fascinating. So there's a lot more research being done with pig organs, and there's a lot coming out of China for some reason. I don't know why is China big on pig anatomies, replacements, something weird there. But anyway, so valve replacements can last up to 10 years. They are susceptible to thrombus formation. So patients are required to take at least a daily aspirin to prevent as an antiplatelet. So be aware of our bruising and bleeding risk. We'll look at that in a little bit. So here's some pictures of different what would happen with stenosis. So this first picture here, again, too narrow of an opening, not enough blood advancing. Here's a picture of that regurgitation. So we're constantly just getting backflow. So instead of being advanced, there's portions that are being left behind. Here's the mechanical valve and then a pig valve there. So pretty amazing. Hypertension is a really, really common issue. Around 1/3 of adults have hypertension. 1/3 of those people are undiagnosed. So I think how many people, I think we already answered this and I think I already know the answer. How many people at their clinicals saw their practitioners or anybody in the clinic taking blood pressure? Saw some? Really often or occasional? Once?
Same patient.
So there's one patient who has a history of something and makes sense. Yep. Yep. So going back to, I think we can change someone's life if we detect they have high blood pressure for them. We're seeing no one blood pressure reading means anything. But if we see our patients twice a week for 3 or 4 weeks and they're constantly high blood pressure and they're undiagnosed, that's now a conversation to have with the person and their primary care provider. As we'll see, high blood pressure can cause congestive heart failure. It can cause that damage to the inner lining of these blood vessels, which will promote the growth of those plaque buildups and arteriosclerosis. So coronary artery disease and peripheral vascular disease are both can be caused from hypertension. So if we can educate our patients and reduce this blood pressure early on in life, I think we can really change the course of somebody's life. So I think we could do a better job in the physical therapy world, at least just taking blood pressures. So men are more likely to have hypertension above less than 55 years old. Women are more likely to develop hypertension after menopause. African Americans have higher prevalence of hypertension than other races. So known as a silent killer, there's three major categories. Primary is idiopathic, categorized as 140 over 90. That's what we'll focus on for this class. There's other categories that we could have, but we showed you those before. Secondary hypertension is as a result of some sort of other endocrine or renal disorder, and then malignant hypertension is a hypertensive emergency with extremely high blood pressure that typically results in organ damage. So a terrible thing. So again, the big problem is the could lead to left-sided heart failure. It could lead to left ventricle hypertrophy, which will lead to left-sided heart failure. Could also lead to peripheral vascular disease and coronary artery disease. I think one of the problems with hypertension, and this happens with a handful of different disorders, a third of adults have high blood pressure, so it feels like it's not that big of a deal. Oh, everybody's got high blood pressure. It's fine. No, it's not. And all you've got to do is work with somebody with any of these other conditions, with left-sided heart failure, peripheral vascular disease, or coronary artery disease, to know that it's not nothing. And if we can be preventing these way earlier on, we're going to be saving a heck of a lot of lives. Hypertension is idiopathic. A lot of different factors contribute: age, genetic factors, lifestyle characteristics, high sodium intake in their diet, excessive alcohol intake, prolonged stress. So we can monitor and we can adjust all of these things, and we can educate on. We can't adjust genetic factors or age, but man, those lifestyle changes, those lifestyle choices, we definitely can in diet and exercise. So we'll look at different medications for it. The major ones: mild diuretics, ACE inhibitors, other antihypertensive, we'll look at in a little bit. For us, education on improving lifestyle changes, 30 minutes of aerobic exercise most days of the week is the general recommendation, but diet changes as well. And again, one thing I was just saying is, there are patients that have been in your first rotation that had high blood pressure and they didn't know about it because their doc either didn't check that day, maybe they haven't been to the doc in years, maybe they went to the doc and they just never checked, maybe the doc went and it wasn't that bad that day. So I think more patients have high blood pressure than what we're capturing, and I think that's something we can do better in the physical therapy world. The big risk for us, and we'll look at this when we dive into medications a little bit more, the big risk of these, so we have high blood pressure, so we get put on medications to lower blood pressure. The risk is the blood pressure goes too low, and now we're at risk for orthostatic hypotension. So when somebody has high blood pressure, they say, "Oh, don't worry, I'm on medications." Well, great. Now I think your hypertension is probably controlled, but I have to be aware that it might be going too low. And actually, this happened just to my neighbor. My neighbor was on blood pressure medication for years. He he got divorced, and then he dropped 40 pounds, because apparently being back in the dating market and when you're over the age of 60, that's an important thing to do. So he dropped 40 pounds, but he was getting lightheaded all the time now. And I was able to help measure his blood pressure. And geez, because he lost all that weight, his blood pressure, he was on medication. He actually needed to get off of his blood pressure medication because it was between the weight loss and the meds, he was going way too low. So that happened just in the last handful of months. So have to be aware of that. Orthostatic hypotension, we talked about quite a lot there too. So we're going to look into some medication stuff now. Really important to know the classes of medications, certain examples of it, side effects of that cardiopulmonary, but also each medication will have some sort of PT implications to know of as well. So there's a ton of information here. Now, when I was in grad school, we had it was a 3 credit course on pharmacology. It was all semester long, 3 hours a week, every single week for an entire semester. We talked about pharmacology. We have about an hour. So we're going to do everything we can. I'm going to show you everything we can. I'm going to try to make sure that you understand the most important things, and I'm going to open the world into how much you can know about. So it can get complicated quick. I think it's really important information because our patients will have risks because of these medications, just like we saw if somebody has high blood pressure, they're on blood pressure medications, their risk is now blood pressure being too low. And if they're at risk for orthostatic hypotension, I need to be aware of that because guess what we're going to be doing with our patients? We're going to be moving positions, supine to stand, sit to stand. So I have to know about that. So there's certain things we have to know. There's other things we have to know to improve compliance. And man, if we're really good at medications, our patients will be having side effects or negative effects that we might be able to call the doc and say, hey, doc, the patient is experiencing these symptoms. I saw that you put them on this medication. That's one of the side effects. I don't know if there's a different class of drug that you want to do or different dosing, but I'm seeing this negative side effect. Man, that right there improves the patient's quality of life significantly if we can catch that. Our patients will be experiencing that, and the more knowledgeable we are on these medications, the better. So I'm going to go through these one by one, and then I have a separate chart, and we're going to go through some other learning activities to try to really cement this in our heads. So what I will tell you is I think this information is really dry, especially us in the physical therapy world. I think it's easy to sit and listen to a lecture on congestive heart failure because we could picture what the patients are. We could picture the tests that we would do. We can picture the treatments. It's a little bit more interactive. This stuff can be really dry. So if you're having trouble paying attention during this, get up, walk around, however you need to, throw water on your face. Have Alan sing to you if you need, like however you need to. You don't mind singing, do you? What? That's the line we find. Alan, I've never said no to me before. You've always just been my yeah, sure, anything you want, Josh. But now the singing's the line. I finally found where Alan says no. All right, so he'll just dance for us then if we need. So the first ones we talked about a little bit, vasodilators or nitrates. Nitroglycerin is the number one that you have to remember. So these other medications exist. Nitroglycerin, when you think extreme vasodilator, nitroglycerin is the one you have to know. So massive coronary artery dilation, decreases preload and afterload, side effects, headache, dizziness, hypotension. So you can imagine if it's a vasodilator, how that might plummet the blood pressure right away. So monitoring for blood pressure, risk of orthostasis, that drop in blood pressure, avoiding heat modalities could be important with this. I think the most important thing with this, when somebody shouldn't be using nitro daily. Like that's a big problem. This should be, I'm experiencing angina. I might take it, even at the worst case scenario, maybe once a month a person should be taking their nitro. So usually it's the kind of thing that's hopefully prescribed and never touched because it means we're managing their angina or heart related symptoms. But if somebody's prescribed nitro, what is the number one thing we have to do during physical therapy? Make sure they have it on them. Yeah, that can't be one of those things where, let's say somebody with knee replacement showed up at your clinic, to midpoint of the program, not first stages where they're just crying about pain, not end stages where we're not worried about anything other than just get out of here. Midpoint of the 4 or 6 weeks after surgery. You all know what about 4 or 6 weeks after post-op knee replacement looks like. Every person's had someone like that, right? What if that person forgets their nitro that day? Oh, I took my wife's car, not mine. It's in my. So if they have stable angina and we know they're rate pressure products, then maybe we could use that. Maybe. What other options do we have? So give me what's the 4 to 6 weeks after knee replacement, what's the treatment program? Give me some elements of what a 30 to 40-minute treatment would look like. And then get improve range of motion. Good. What else? So both flexion and extension. What else? Strengthening. Good. What else? Maybe some balance work. Maybe some gait training if we're changing. 4 weeks out. I think most part patients are have weaned off of their assisted devices, but some still linger. Some are still using one crutch or a single cane or something like that. So maybe we're doing some gait training. All right. So if someone forgets their vasodilator that day, their nitro, can we still proceed with any treatment? Yeah. So some of the stuff I think we could. Can we work on range of motion when some?
Yeah.
Good. Although, is there any extra precaution we should take? Exactly. That's exactly it, Adriana. So just sometimes we just look at our patient and say, I'm going to crank on this knee, man. Try not to swear because we got young kids around. And we just lean into them. Has anybody ever had to do that? Somebody, right? So I would say today's not the day to do that level. But can we go that sub-maximal? Listen, pain can increase heart rate, which can increase demand. We could stir up these angina symptoms. With you not having nitro today, we're still going to bend the knee, but we're going to go sub-maximal. That if we were to use the RPE scale, instead of it being in the 4 to 6 range, we're going to go down to the 2-3 range. We're going to get some motion, but we're just not going to. We know we're limited today because we don't want. That's how we're going to be extra cautious. How about balance exercises? I think in general, no. Although, has anybody ever seen a patient with high anxiety about falls? So if it's that type of person where they're becoming really anxious, then that is something I'm going to treat a little bit differently and say anxiety can cause these angina. And you know what? With your history of anxiety and you don't have a nitro on you, I'm not going to see you at all today. So I might make that decision. But I think for most patients, balance tasks are still on the table. How about strengthening? Start pumping the brakes real hard on that. Real hard on that. Especially if it's high intensity or adequate load, and especially if they like to use the Valsalva maneuver. Has anybody worked with somebody that no matter how hard you teach them, they still use the Valsalva maneuver all the time, right? So that category of person, I'm not doing any strengthening whatsoever. For others that can control their breathing, then I might entertain the thought of a really low load, but probably not. I'm probably erring on the side of caution saying we're not doing this. So anyway, so I think the take-home message for this is nitroglycerin is the vasodilator. It's the most common one that's prescribed. It's an emergent, not necessarily an emergency, but as needed, and it hopefully isn't that often. That's the big thing to remember for that. Statins are aimed to reduce LDL cholesterol. LDL cholesterol is the unhappy cholesterol. HDL is the happy cholesterol. So those are the good ones. So statins are aimed to reduce LDLs, stabilize plaque buildup. So the nice thing about statins is they typically end in the statin is usually at the end of the drug name. So atorvastatin, rovastatin, those are all, anything with statin in it is aimed to reduce cholesterol. And we've seen how cholesterol, that's where the plaque is going to build up and can lead to coronary artery disease, peripheral vascular disease. Someone who already is already prescribed a statin might already have those symptoms, might not. They might have gotten it caught early on. So the big thing for statins that we can look at is unexplained muscle soreness or weakness. I was actually at that course that I was at the beginning of the month, and one of the instructors said that she was working an outpatient, and the woman was complaining of muscle soreness. and was tying it to physical therapy treatment. And they were digging through the notes like, God, we changed this exercise, but it shouldn't have been enough to create this muscle. Like, why? And it came out that, oh yeah, by the way, the doc increased my statin last week. And then the brilliant PT said, oh, well, that's why you've got this muscle soreness. Let's call the doc and tell him that, because now maybe we need to reduce this statin or find something else. Man, so when I talked about we need to know about our drugs and side effects to it, how many people would have their patient coming in complaining of added muscle pain and would say, oh, it just means it's delayed onset muscle soreness. Either we'll keep going and it's not that big of a deal, or most of the time we would probably regress because we do want to respond to our patient's subjective complaints, reduce our physical therapy intensity, when really that's not the problem. So now we're just giving them less physical therapy for no reason. So I think the two major take-home points on statins is on a test question, again, whether it's a test in this class or the licensure exam, if the word statin is at the end of that medication, it means it's a statin and it's aimed to reduce cholesterol. And the major side effect is the unexplained muscle weakness is probably the biggest one for us to know about.
Weakness and soreness, or just
Yep. Yeah. Mineralocorticoids receptor antagonists. Now, one thing I will say, these all have the categories of them have long names to it, and it has to do with the pharmacokinetics and where in the physiology are these medications interrupting the cycle or adding to it, modifying it. So when you guys took human physiology, I mean, you went through a bunch of cascade of events. First, this hormone is released, then it does this thing, then it breaks down into this enzyme, then this enzyme does this other thing. Do you guys remember that nightmare in physiology? So if we remembered those things, then with pharmacokinetics, we get to say, all right, well, this medication comes in and interrupts the physiology at this point, which creates this other cascade. That's what pharmacokinetics are. And that's where a lot of the titles of these get to come from. Again, I don't think we have enough time to go through that. I think it would enhance our education, but I just don't think we have enough time to do that. And especially, I mean, I took three, in grad school, I had a whole class with it, and man, it made my head spin. And I think the pharmacist who was teaching us probably thinks the same thing teaching that course that I feel right now. She probably thought, gosh, I got to teach all of this information. There's not enough time. This is our whole career that we have, 6 years of schooling to learn all this stuff. And you guys get one class. So there's just not enough time. But that explains why some of the categories of medications are so long-winded. So what these are these are a diuretic. So they're aimed at getting rid of excess fluid. This is potassium sparing diuretic. So other types of diuretics are not potassium sparing. So we would be able to see that if we have more blood counts, and we could look at electrolyte counts too. Going back to our lab values and the norms, that is something that we potentially could be catching to say, oh, this person's on this diuretic, but their potassium levels have dropped. Maybe we need to call the doc and ask, do we need to switch this to a potassium sparing diuretic? So spironolactone is the one that I see most often. Again, just because I see it most often doesn't mean others don't exist, but that's the one that I see most often. We have to monitor for weakness, arrhythmias, and anytime we're on a diuretic, we're going to be at risk for orthostatic hypotension. Inotropes are pressors. Dopamine is a big one. Epinephrine, norepinephrine are all possibilities. This increases the cardiac contractility and blood pressure. So you are probably going to be seeing these a lot with congestive heart failure. If we can increase the heart contractility, that means we're going to increase the amount of force that we're going to be able to squeeze that heart, which will in turn eject more blood per contraction. So congestive heart failure is a likely a diagnosis for these type of drugs. So we have to monitor blood pressure closely because we are going to be increasing blood pressure with it. So, man, it is really tough because now this person, and this happens so often where, okay, well, this person has congestive heart failure, so I need to give them a pressor. This pressor caused their blood pressure to be too high, so now I need to give them a antihypertensive. So now it's not only one medication, now they need 2 or 3 medications because the one medication solved the major problem, but added another. And we've got to add some more medications for another. And guess what? It can go on and on and on. I've had patients on over 30 different daily medications. It can be, and it's wild to see someone go down that road. So we have to monitor heart rate and blood pressure closely. In the ICU, activity is often limited with this. Diuretics, furosemide is the #1 that I see. Hydrochlorothiazide is another one that I see, but furosemide is the #1 that I see. So those aren't potassium sparing. The potassium sparing one that we just talked about is also in this category for some reason. I don't know why I put it there. So again, the #1 thing we're going to do is decrease blood volume with this, decrease edema. Hopefully it's going to lower blood pressure. The risks are electrolyte imbalances, dehydration, dizziness. So our job, improve hydration. All of my patients on a diuretic, which there's plenty of them, they always have the same complaints. I'm going to the bathroom too often. I don't want to go to the bathroom this often. So their compliance of using this medication drops. But also, one of the things they try to do is, I don't want to drink that water. I'm just going to have to pee in 30 seconds. So my patients on diuretics become dehydrated all the time. They act like they have rabies. They're afraid of water. They're avoiding it when now that's going to create other problems. So it's up to us to encourage it, monitor blood pressure for cramps and arrhythmias and other things like that. But really, how can we improve compliance can really be a tricky thing for us. And that's something that I get to talk with my nurses a lot about and try to help them along the way too. I think the #1 thing we can do for our patients with diuretics is how can we get to the bathroom efficiently? And in the home care world, that's usually my role. If I can get to the bathroom a lot easier, do you think it wouldn't be that big of a deal? So calcium channel blockers end in pine. Amlodipine is the #1 that I see. There's also a couple of others. Amlodipine is the #1 that I see. This will decrease heart rate, contractility, and blood pressure, create vasodilation. Side effects include bradycardia, hypotension, dizziness, and then edema potentially. So we have to monitor heart rate and blood pressure, be aware of orthostatic hypotension, fatigue as possible. Beta blockers end in olol. Metoprolol is the #1 that I see. This also decreases heart rate, contractility, blood pressure. It also decreases myocardial oxygen demand. So we have a lot of the same problems, bradycardia, fatigue. Depression is an interesting one, and I forget exactly why depression is a side effect, but that is something we definitely have to be aware of. The big thing I think for beta blockers, and this is the thing I would circle in your notes, is the blunted heart rate and blood pressure response with exercise. So if someone's on a beta blocker, and it can happen too with these calcium channel blockers, but with beta blockers, the number one thing, if we throw them on a treadmill, their heart rate's not going to increase because that's the goal of the medication. So we have to use RPE as our tool for exercise intensity rather than heart rate response. ARNI, looking good, Reed. Look, hey, what are you? You didn't have to. Did everybody see? Nobody else saw that? He said, "Yeah, Josh, looks great." Like, what the heck was that? Good to see you too. ARNI, I forget what this stands for, and again, it has to do with the mechanism in which it impacts. Valstarin is the number one that I see, the number one medication I see. This decreases blood pressure, improves survival in heart failure. Got to be aware of hypotension is the big thing for that for us. ARBs and then sartan. So there's that extra R. Sometimes I get these when I read these quickly, I confuse them with statins. So try not to make the Josh mistake. Lostarine is the number one that I see for that. This blocks angiotensin 2, which creates vasodilation to decrease blood pressure. So again, anytime we're decreasing blood pressure, we have to be aware of low blood pressure. The big thing with ACE inhibitors, if we go back, oh, we didn't do ACE inhibitors yet. Never mind. We'll do ACE inhibitors next. So ACE inhibitors create a cough. That's one of the main side effects. These ARBs are used more and more frequently because they do not create a cough mechanism. And it has to do with where in the body the ACE inhibitors, that process takes place in the lungs. So these are being used more and more rather than ACE inhibitors. ACE inhibitors were used a lot 15, 20 years ago, but these ARBs are used more and more. ACE inhibitors, we were down to slide 115, just so you know. Yep. So ACE inhibitors end in prils. Lisinopril is the one that I see most frequently. This also creates vasodilation, decreases blood pressure. Side effects is the dry cough. So if our patient has this persistent cough, then potentially we might be able to call the doc and say, "Hey, doc, I'm seeing this cough. It's bothersome to the patient. Maybe we want to try to switch into an ARB." That's up to them to know. It's up for us just to relay the information. It's up to them to make the decisions because there could be other reasons why they can't do that. But I think ACE inhibitors end in pril. Side effect is the cough. That's the big thing to underline there. So our job, again, anytime we're decreasing blood pressure, watch out for low blood pressure. And then the persistent cough is the thing to also monitor. Antiplatelet agents, aspirin is the number one that we see. Plavix is also another really common one. These are going to prevent platelet aggregation, which is going to decrease the risk of clot formation. Couple of things that we have to be aware of: GI upset, but bruising is probably the more common one for us. So we're going to have to be really careful with our manual techniques. Our patients can bruise easily. Does anybody have any relatives that just have random bruises and they couldn't even tell you why it happened? Yeah, you have somebody, Ashley? You have somebody with, or no, you weren't talking to me about that? Okay. So does anybody else have a relative that is usually on some sort of blood thinner antiplatelet and they get bruises all the time and they don't even know, I don't know what that bruise is from. That happens to me all the time because one of the things in working with geriatrics is you have to be aware of elder abuse. So you have this bruise on your arm. What's it from? Couldn't even tell you. And it's not there. There's a difference between I can't tell you I'm hiding negative information versus I don't know, it could be anything. The blanket landed on me too, you know, my dog jumped on me and gave me these bruising. So, Norm Macdonald has a good bit on that with one of his the punchline is, oh, I don't know the wind. Like I didn't know at a certain age you had to be afraid of the wind. But anyway, that's just all pause class and watch Norm Macdonald bits. This is our Norm Macdonald segment of the class. Anticoagulants, warfarin, heparin. Warfarin's probably the number one that we see. So this inhibits clotting cascade, prevents thrombosis. Somebody on this type of anticoagulants will need their blood levels checked. Usually weekly is what I see. Might be more frequently in the inpatient world when they're starting on these drugs, but huge risk for bleeding. So we have to be extremely careful with our manual techniques as well, avoiding tissue work, monitoring for bleeding. There's also, we have to teach our patients on their diet because there's a lot of things in the diet. Grapefruit and spinach are the two big things. The leafy vegetables, I should say, not just spinach, but leafy vegetables, because that can compound the effects. So usually, if you're going to eat that salad, skip one of your warfarin pills for the day. Again, we wouldn't be telling them. We would be educating them, saying, if you eat that food will interact with this medication and create a bleeding risk. Call the doctor to figure out what to do. And the doctor gets to then say, whoever prescribed the medication gets to say that. Antiarrhythmics. Digoxin's one of the common ones. Big side effects with digoxin, digitalis. So this is supposed to suppress abnormal rhythms, but it can cause bradycardia. What's that mean again? Slow heart rate, dizziness, and then the visual changes, particularly with digoxin. So we have to monitor heart rate and rhythm and be aware of and report vision changes. So here's a couple of summary slides. Here's a handful of medications that could be used for blood pressure and rhythm control, and one things we'd have to do, clotting and lipid control, and what we would have to do. So let's do this. Before we get into cardiac rehab, let's take another short break, 10 minutes, and then we're going to do some stuff to try to learn this stuff a little bit more, okay? Let's take a little break. All right, do we have lunch break? We do, right? What time is the lunch break? Oh boy. All right, so we'll have to break this up between before and after. So in Blackboard, I also put everything onto one page for you. So you can look at all of the 13 different classifications, classes of medications, the common names or the common medications, both generic as well as brand names. I think that's one of the other tough things about medications is, you know, the generic name versus the brand name. We got to know them as well. So that's another layer of difficulty. But here's what I want to do. I put a bunch of flashcards. I tried to give each pair flashcards because we're going to do some other stuff with flashcards later. But here's what I think for flashcards. You got those opened up? So here's what I want to do at first. 13 cards. And on one of them, one side, I don't care which side you use, but write down the classes of each. So one card is going to say vasodilators / nitrates. Another one's going to say statins. Another one's going to say mineralocorticoid receptor antagonists. Another one, inotrope pressors, diuretics. So we'll move on and on. So 13 cards like that for now. Okay? Where's Jasmine today? Do you know? No? She all right? Okay. All right. Tell her I miss her and I hope she's doing all right. All right, I'm gonna pause you guys right there. So my hope is that games like that can help you study in a little bit more interactive way, especially if you do it with someone else. It can be a little bit of fun, and someone else can guide you into what their knowledge is and fill in knowledge gaps. It also helps you, at the end, if you've got 10 cards that you don't know where to go, guess where you need to study? Those 10 cards, right? So it helps guide you. It's almost like, how many people like doing like Quizlets or other quiz questions to study, right? So the great thing about those, if you can't get that those questions correct, you know where to study. Same thing for this. What I also like about this, this doesn't happen all that often, but on the slow periods at work, can you go through this stuff? So this becomes a nice travel task that you get to just start flipping through. So anyway, we're going to go through our next thing here, which is cardiac rehab. So cardiac rehab, comprehensive exercise education, lifestyle modification program to try to get our patients to have optimal physical, psychosocial, and vocational functioning. We want to control symptoms, improve exercise capacity and tolerance, and then improve overall quality of life. Some of the evidence regarding reducing mortality is a little controversial. Sometimes some research says it doesn't do anything to reduce actual mortality. Others, it says we do some good stuff. However, cardiac rehab is great at improving quality of life, improving exercise capacity and tolerance. So I still see a ton of value with it, despite maybe mortality being the ultimate goal, maybe that being suspect. But quality of life definitely matters. So there's technically 3 phases: inpatient, outpatient, and then the last phase is maintenance phase. You're off on your own. Don't forget to exercise. So we're going to focus our time on inpatient and outpatient rehab. So inpatient rehab, phase 1 cardiac rehab, traditionally begins in the acute care hospital. We want to focus on assessing the patient's hemodynamic response to activity. So that's blood pressure, heart rate, things like that for during exercise. Increased independence and functional mobility. Hospitals worried about, can we walk to the bathroom? That's the big thing we're looking at. But bed mobility transfers, gait, stairs, ADLs, all of that kind of stuff counts. So there's a lot of different inpatient rehab programs. So most of the time, whatever hospital setting you work into will have their own structure to it. So there are some variations to it. I have some examples that I think are a good thought to have in our head. But again, if our facility has their own program, we're going to implement that program. So we have a few different levels to it. I'll show you that next. And we're going to climb that ladder until the patient has some struggles. We can climb multiple levels all in one visit. So it should be individualized to the person. So starting with sitting at the bed with stable hemodynamics, again, blood pressure, heart rate, all of those things. Once that happens, then we'll look at transfers. If they can transfers with stable hemodynamics, then we can start looking at ambulation and all that other stuff. So here is an example of different levels of cardiac rehab. So a lot of the times they're described, and in our literature, it's described as to how many METs this activity is. Who can give me a summary of what a MET is? Just one at a time, please. That's a good, yeah, not necessarily a test. I think, the amount of energy required for this activity. And a MET is calibrated with size and body weight in mind. So that's a nice thing about MET. And I think the other thing for us to really understand, and it helps us understand METs, is at rest, sitting here, you guys are at 1 MET. Just sitting there, you're at 1 MET. And then if we were to go up to 8 METs, that activity is 8 times more challenging than just sitting here. So that's the thing to keep remembering is the number of METs is how many times harder is that than just sitting here. So when we do our cardiac rehab, our phase 1 of cardiac rehab, Start at level 1, between 1 and 1.5 METs, just sitting at the edge of the bed. That's what we're looking for. If the patient does well with that, we can progress to level 2, between 1.5 and 2 METs. So now twice as hard as just sitting there. So sitting for 30 minutes, 2 to 4 times a day, different leg exercises. Now this person can transfer to a commode instead of you staying in bed. Limited ADLs. Stage 3 or level 3, 2 to 2.5 METs. So maybe this includes walking up to 5 minutes, 3 to 4 times a day. And yeah, for our inpatient cardiac rehab, we might be seeing somebody 4 times in that day. It might only be for 5 or 10 minutes at a time, but we might be seeing them 4 times a day. So we're seeing the same 4 people, but we only saw 4 people that day, but we saw them all 4 times a piece. Like that's it can be a lot. So if we go up to level 4, that's hallway ambulation 5 to 7 minutes. Level 5, 3 to 4 minutes, ambulation up to 10 minutes. Some arm exercise, although we have to be careful if we have sternal precautions, we have to be extremely careful. Also, arm exercise will elevate the heart rate faster than the lower extremity. So 3 miles an hour on an upper body ergometer is more cardiovascularly taxing than 3 miles an hour with our lower extremity bike. So using a bike with lower extremity. So just remember that. And then we'll progress all the way to level 6, 4 to 5 METs, progressive ambulation, maybe stairs, and then start educating on outpatient cardiac rehab. Outpatient cardiac rehab. So one thing, a delay of beginning phase 2 by more than 30 days is a predictor of decreased improvement in exercise performance. So we want to start these as fast as possible. Patients are monitored. A lot of times they're monitored in groups. Education classes are also used. I'll go back for a second. Our patients and their inpatient, they're hooked up to EKGs throughout. So we're monitored. All of their vitals and everything, their EKGs are read the entire time. So that is nice that we get to have that data. Also, what's really important as we do cardiac rehab with our patients, because we're going to be the ones exercising with them, that is our sole job, we're going to have to become competent at reading EKGs and at least where is the major problems here. So that is something we would have to be aware of. And when I say patients are monitored outpatient, they're typically either EKGs or even single lead EKGs happen a heck of a lot. And especially with the technology we have now, it makes it really, really easy. Anybody go to group exercise class where the whole group has heart rate monitors? I think Peloton, does Peloton do that? Anybody have a Peloton? I don't know if they do heart rate, but they can do other things with their Pelotons. How about any other exercise classes that you wear a band? And I know some of them have the heart rates displayed on the screen. Oh, I think that's the one I'm thinking of. Yeah. So, I mean, we can do it in general fitness classes. We can do it in cardiac rehab as well. Here's a band. Put this around either your chest or a watch, and now we get to monitor all at once. So it helps out quite a bit. Education classes are also used as well. So exercise prescription and cardiac rehab. Mode, large muscle groups of aerobic exercise. Walking, jogging, cycling, rowing, stepping. Upper body ergometer is UBE, upper body. That's the hand bike. So, and I like, I forget if I got this from a book or if I typed this out, but as enjoyable as possible. So that is one of the really tough things about cardiac rehab. Most of these people are in cardiac rehab is because they've been afraid and don't like exercise to begin with. They've been afraid to exercise and then they just dislike exercise. So part of our job in outpatient phase 2 cardiac rehab is to figure out what is enjoyable, and let's do that more and more. So when we're doing cardiac rehab, we're really just focusing on getting that heart working better. We have to remember, though, if my patient wants to get better at walking, which exercise modes should I be choosing? Probably something walking related, right? So that specificity of training does matter, at least at the later stages of our cardiac rehab. So 3 times a week as a minimum, as many days a week is preferred. Duration is variable, but most protocols are for 12 weeks. There is some research that longer than 12 weeks equals better adherence and outcomes, but most protocols that I see are 12 weeks long. So we have a cool warm-up period, a conditioning period, and a cool down period. The duration of exercise period is at least 20 minutes. Early on, we can break into 10-minute segments, but we want to get up to that 20-minute prolonged as fast as possible. The intensity is 40 to 80% of VO2 max or 55 to 90% of heart rate max using the Carbonian method. So VO2 max we can use, but again, that was back with exercise testing. That's where we have to add the added mouthpieces to measure that directly. I do not see a lot of VO2 max being tested. A lot of our patients will have exercise tolerance tests, but without that component. But we can do it with our heart rate max. We'll calculate some stuff in a little bit. But even if we can't do that, man, RPE shows up yet again. It is so easy just to use that RPE. And especially if we've got a patient, what kind of medication blunts the heart rate response? Oh, we just had that card in our hands. Is it beta blockers? I think it was beta blockers. And yeah. So if our patients are on beta blockers, now, first of all, beta blockers, do you think somebody with a cardiovascular disease might be on the beta blocker? Yeah. So we can't use heart rate for that person. So using RPE is our sole method on how we can do that. And again, I like using the original Borg when I'm trying to measure it for exercise intensity, just because it does correlate with that heart rate really well. But we can use the modified one if we need to. The exercise intensity could be as low as 40% in the earlier stages. And I think, I say it all the time. I'll say it a bunch more times to you. The art versus the science of physical therapy. There are some reasons to underdose an exercise in early stages to get the patient compliance, maybe reduce some fear or resistance to even participating in exercise, and then we can ramp it up. So there are some artistic reasons for that, but we want to make sure, we could start at 40% heart rate max and still say, no, we did a good job for this week, but we want to progress them up to that 55% threshold as fast as possible. And we progress to the patient's abilities and symptom control. We could add resistance training. If we have sternal precautions, we have to be really cautious with that. So we can't break sternal precautions. But in phase 2, we get to add resistance training. 12 to 15 reps per set, 2 to 3 times a week, intensity of 30 to 80% of 1 rep max would all be fine. So here's some ways to calculate max heart rate and target heart rate. So I know in PTA 1, we focused on the simple formulas. So max heart rate is 220 minus your age. We've done that. Tanaka's formula is a little bit more accurate, especially for the older adults. The younger adults, 220 minus the age is great. It's fine. The older adults, that math starts to break down a little bit. So why don't you do this for me? Calculate your max heart rate using Tanaka's formula and compare it to what the simple formula. So 208, so take your age times 0.7 and then take 208 minus that number. So if you're 10 years old, 0.7 times 10 equals 7. So 208 minus 7, 201. What kind of numbers we getting? A little lower. Tanaka's a little lower. Yeah. And I think for our cardiovascular or cardiopulmonary patients, the more conservative we are is probably the safer. So I really like using Tanaka's formula, one, for older adults, because the simple math formula falls apart the older the adult is. But also, I like being conservative when I have my cardiopulmonary patient. So we could also calculate just multiply that number times 55% and then multiply it by 90% to get our target heart rate range, the low end versus the high end. The Carbonian formula is a lot more math, but it is much more accurate for our cardiopulmonary patients because, one, the older the patient, the more accurate it gets to be. But also, if we have an elevated rate at rest, the simple formula breaks down. It doesn't work. So if what's norms for resting heart rate for adults? 60 to 100, 40 to 60. What was 40 to 60? So 60 to 100 is normal, what's considered normal resting heart rate. Do you think some of our patients are going to have an elevated heart rate beyond 100 just at rest? Yeah, definitely. Especially if they're trying to compensate. If they've got congestive heart failure, they need to pump that heart more often because their ejection fraction is less and we just got to pump up more. Yeah, definitely. So there are times in which we'll have our patient who they're older and their resting heart rate is 110. And once we do the simple math, oh boy, this person's already in the training zone. Well, that's not true. So here's what I want you to do. Using this Carvonian formula, figure out your so we need to figure out, first off, we need to, what's great about this is the math incorporates your resting heart rate for it. So let's do this. Take your partner's resting heart rate, 30 seconds, and then plug in your partner. So Reed's going to calculate Alan's lower heart rate range and then higher target heart rate range based on using his resting heart rate. So Reed is going to measure Alan's resting heart rate and then punch in the numbers. Got it? All right, so let's do that real quick. You can do that for a couple minutes. All right, so a little bit more math with that. But for our older patients and for our patients with an elevated resting heart rate, which we already know a lot of our patients with cardiopulmonary disorders are going to have an elevated heart rate as part of their compensation for their disorder. These formulas, although a lot more complex, are going to give us a way to attack someone, to treat someone with an elevated heart rate. Because if their resting heart rate is 110 beats per minute, and we have to tax their system, we have to overload their system. That's one of the principles of exercise. We need to overload that system. Man, if their resting heart rate, if they're 60 years old and their resting heart rate is 110, if we just did the simple formulas, we'd have to lower their heart rate to get into a training zone. And that's not true. We need to add activity to tax the system for that overload. So these Carvonian formulas should be the one we're using for our cardiopulmonary patients. Some of our EMRs will be able to do that math for us. Some of them won't be. So hopefully your EMRs will be able to do the math part for you. But if you can't, you got to figure it out. So I think the Tanaka's and the Carvonian formulas are both new there for that one. So some of the educational components in cardiac rehab. Now we can definitely, if our patients aren't in formal cardiac rehab, we can take cues for this and we can start modifying some of our education for our patients if they don't have cardiac rehab, if they have just risk factors. But some of the classes, they'll go through activity guidelines, exercise prescription, leisure time, rest time, self-monitoring of RPE, heart rate, dyspnea scale, blood pressure, symptom recognition and response. So this is, weight gain is crucially important. I should have expanded on this more for the congestive heart failure section. A 2-pound weight gain in 24 hours or 5 pounds in a week is considered call the doc. Call your cardiologist. Most of the time, the cardiologist will say, double up on your nighttime diuretic and then call me tomorrow. Most of the time, that's it. But if we first of all, what does that weight gain mean for patients with congestive heart failure? We're retaining more and more fluid. Does the heart like more and more fluid for congestive heart failure? Nope, it already has too much. So if we're retaining more and more, it's a problem. And if we ignore the day one, one day, 2 pounds, I'm not going to worry about it. I'm not going to take another pill. I don't want to go pee anymore. I've had patients make that decision. But what do you think is going to happen to that person eventually? Over the next few days, what's going to happen? They're going to go to the hospital. Eventually, they're going to have so much fluid and the heart can't take it. And now all of a sudden, they're going to have signs and symptoms of a heart attack. They can't lay flat. They can't I'm breathless out of at rest now instead of with activity. Everything is going to get worse. So we really have to make sure that, and that's something we should be. Our patients with congestive heart failure should be weighed daily, and we should see the log somehow. However they're recording it, we should be able to see that. What was your weight today? What was your weight today? So 2 pounds in a day or 5 pounds in a week. I had one patient. They understood the 2 pounds in a day, but not the 5 pounds in a week. And she was gaining a pound a day for a week. So she was 7 pounds heavier, but she said, no, I'm fine. It was never past 2 pounds. I said, oh, but it's 1 pound every single day. You're going in the wrong direction. Now we have to, I'll get to you in a second. We have to make sure we're educating our patient on that because those people are on the road to hospitalization. They are going. But so often it's just take a again, we don't make this decision. The cardiologists and primary cares do. Most of the time, they just double up on their diuretic for a little while until their weight is back under control, and then they go back to their normal dosing. Most of the time, that's what happens. Man, when our patients say, but I'm going to go pee all the time, I don't want to do that. Well, it's a heck of a lot better than staying in a hospital for a week or, remember the last time you were in the hospital, how much it sucks? Like, yeah. So we can really prevent them an unnecessary hospitalization potentially. Did you have something else, Holly?
Obviously, we don't have to be like, for people, that's not super young, but a woman on her menstrual cycle, you can gain a day or a week. Like,
Yeah.
6 to 10 pounds that.
Yeah,
And then I lose a pound.
sure.
Is that an issue or like?
That's a great thought. Weight gain during menstrual cycles. The patients I haven't seen, it doesn't mean it doesn't happen, but most of the patients we're talking about are post-menopause, so that's not necessarily a factor. But there are some that have. We have patients with congestive heart failure that can be earlier and earlier, so it does happen. So, what do you think our role is?
To just stay on it, update the doctor and document.
That's it.
They all cycle, so it's a 50-50 is what's happening, what is my next
And
step?
yeah, and is there other data that we could try to collect that would help us determine whether weight gain was due to menstrual cycle or weight gain was due to cardiac impairment?
Where
There you go. Where is the weight gain? And if we had right-sided heart failure, HFpEF, HFpEF, not PrEF, PEF. Where would yeah, that's emphysema versus chronic bronchitis. So if they had right-sided heart failure, where would we see the weight gain? Then the legs. And we might be able to use a pitting edema scale or girth measurements. We might be able to add to that. Those are things that we didn't talk about during my time this semester, but we did talk about them in PTA 1. So we might be able to say, hey, doc, she gained 5 pounds, but when I measure the size of her legs, they're exactly the same. So I don't think it's from, but it's up to us just to relay the data that we have. It's up for them to determine what that is. And I bet you, if you were the cardiologist, what would you think? What would you do?
if they didn't let us stay the same,
Yeah, yeah.
then I would say it's probably.
Probably. Do you think you would change any medications or anything else like that? So, and I don't know, this is a really interesting thought. I don't know the answers to that. I bet you most docs would say we're going to double up the diuretic anyway because the heart's more important. I'd rather risk them being dehydrated and too low than to not act and not do anything. Because I think the risk is, yeah, we don't see this swelling, but it's there. Like the scale is telling us a number. So I bet you they would say just do it anyway. But I'm not in that category to make that decision. But yeah, we can definitely relay that information. Other data that we could possibly collect, what would it be? Potentially not, maybe not RPE. I don't know if RPE would tell us whether weight gain in a younger woman is due to menstrual cycle or a progressing cardiovascular, like congestive heart failure. I think all of our vitals would tell us. So if their resting heart rate was typically in the mid 70s, but they gained 5 pounds and their heart rate's also elevated, that to me is a heart that is telling me the heart is a problem. Like the heart, I'm collecting more data and it's telling me that the heart is a problem. Versus if it was weight gain for other reasons, and the heart rate probably would be unchanged. But yeah, again, our job is not to make those decisions, but to collect the data and relay it to the right people. But that was an interesting question. Nutrition is another topic that's a heavy topic for a lot of our patients. Typically, they're going to be talking with their nutritionist about that, but we can echo those messages and we can champion the correct things. I think also if you're living with other people, I think education on the household is a nice way to do it. And if anybody's ever seen, getting one person to quit smoking usually doesn't work unless everyone else in the house quits smoking too. So, if one person's trying to quit, the other person's not, the success of that is really, really limited. Same thing for diet changes. If one person's going to start having a healthier nutrition and the other person is still buying candy bars, that's going to be really tough for the person that is trying to make change. So we can have an impact on that as well. Medications, proper use, compliance, I keep talking about. Different side effects to worry about is some other things that we should know and should also educate our patients on. Oh, this ACE inhibitor, you could have a cough. If you do have a persistent dry cough, let your doctor know because they could change dosage or they could change you to this other medication, this ARB medication. When can we return to work and other leisure activities? Return to sexual activity could be very fearful, hesitations. Also, some of the medications like beta blocker blunt sexual responses in men, decrease libido in women as well. So we can talk about that and at least let them know. And there you go. There's another medication. I told you how some of my patients have medication for a problem, then they get put on another medication to combat one of those side effects. So, man, if somebody's on a beta blocker, yeah, they might need to have an additional medication for their sexual response too. So, all things that we can talk to our patient about. General aerobic prescription. This is for all of our patients. So there's plenty of patients. I know we talk about if our patient has a heart attack, they're going to go through cardiac rehab and we get to be really precise. But sometimes our patients just have high blood pressure and we need to give them a good exercise prescription for that. Or as when you guys are either on clinicals or as techs, have you seen someone that after 6 weeks of therapy, that person starts enjoying exercise and says like, what else can I do? How else can I do that? It doesn't happen. It happens frequently enough that we should be ready for it. And I think giving these general aerobic exercise prescriptions is a great way that we can help our patients. So mode, the definition, rhythmic activities using large muscle groups performed continuously. There's a whole bunch of ways we could do that. Various video games nowadays is really nice to see. Consider specificity as conditioning occurs. So initially we can just do anything just to be healthier. That's fine. But if we want to get better at swimming, you better incorporate swimming into your aerobic exercise. There's just a very specific thing that we've got to make sure we incorporate. Intensity, 55 to 90% heart rate max. Or if we did have VO2 max, we could use a VO2 max. But again, most people don't have that measure to them. So we get to use their heart rate max. And if our patients are on one of those beta blockers and still wants it, what's our next tool that we could use if we can't use heart rate max? RPE, you said it. God, how many times have I talked about RPE in the last 3 days with you? So duration, 20 to 60 minutes of continuous activity, could be broken down into 10-minute segments initially, but at least 20 to 60 minutes. Lower duration is acceptable if the intensity is higher. So if they are doing 80% plus heart rate max, yeah, we can cut that down to 20 minutes, no problem. Frequency, 3 to 5 days a week. We've talked about the importance of prevention a heck of a lot. So cardiovascular disease is the #1 cause of death in the United States. And I think, and again, that's why I think even when our patients come to us because they have a sprained ankle, if they have risk factors, we should start talking about it. And of course, we would do the same thing for a woman who has who has osteoporosis or osteopenia. Hey, I see you have osteopenia. Here's a few things you can do. I see you're 50. We got to make sure you're intact and in one piece when you're 70 and 80, but we got to start on that now so that in 3 decades you're not have a lower risk for all these problems. I think we can do the same thing for our cardiovascular disease. And again, it's the #1 cause of death in the United States. So we have a huge opportunity here. Almost 50% of adults in the United States have high blood pressure. I bet you we're over 50% now. This was a few years ago that I put this together. And also in the variety, here's our 3 major ethical guidelines from the APTA. All of them have some sort of language on addressing the health needs of society. So I think right now, interesting of the what's happening with our SNAP benefits and the strain that's about to be on food pantries. So I think right now, if you work at a clinic, you can easily say, hey, put a box in the waiting room. Let's just collect anything we can for patients as they walk through the door. At the end of the week, we'll bring it to the food pantry. We'll do that for the month of November. We'll just try to solve that gap. So that is one way that we could address the health needs of society. That's something that's happening right now at a very immediate level. But I also think addressing the health needs of society means talk to your patient that had a knee replacement. Hey, I see you have high blood pressure. I want to make sure you're getting enough exercise forward because that could cause congestive heart failure, could cause atherosclerosis, could cause peripheral vascular disease or coronary artery disease, could cause angina and heart attacks, but we need to start making sure that it's under control now. So I think we have a huge opportunity here to address the health needs of society just with the patients that are in front of us. I think sometimes when we read these value-based behaviors and other things that we say, geez, how the heck, what am I know the APTA, we're going to different YMCAs for fall prevention. That's one way. Guess what? We can do it just the patients that are just in front of us. We don't have to do something extra for that. So how do we apply it? So anytime the patient has risk factors, we can encourage a healthier lifestyle. So the way we can think of this is ABCDE approach. 1, aspirin to reduce, that's an antiplatelet, so reduce the risk of those plaques building up and reduce the risk of blood clots. Blood pressure control, cholesterol reduction, and cigarette cessation, diet and diabetes management, and then exercise, and then also economic and social factors we can all factor in to our conversations. This is the sentence, advocate a culture of physical activity. So 150 minutes a week. I think sometimes when we look at our exercise prescription here, I think a lot of patients would get overwhelmed with these numbers. 55 to 90% heart rate, Mac. What does that mean? What are like, how do I know this? So we can definitely spend time to do it. Our more engineering, CPA, numbers type driven people really enjoy having things broken down with that. But I think some of our patients get overwhelmed with it. So I think we can simplify it by just telling them 150 minutes a week, moderate intensity on that RPE scale. And if we can get them to understand that, great, we're happy. So brisk walking is as little as brisk walking is a perfect way to do it. So could be broken up in as little as 10-minute bounce, 20 to 60 minutes of continuous preferred. Moderate intensity shows greater compliance than vigorous, although we did see how sometimes HIIT training can improve the cardiovascular system to a greater degree than continuous exercise. But if we're worried about patient compliance, the lower intensity but longer duration tends to have a better compliance. Not everybody's the same, but that is something for us to consider. 75 minutes for vigorous intensity exercise. So sometimes, what's one of the excuses we always hear is I don't have time. Great. You have an hour a week. We're asking for an hour and 15 minutes a week. How much are we scrolling on TikTok and Instagram? Like, we've got time. You have time. So if you're really pressed for time, then yeah, we can still fit it in. It's an hour and 15 minutes a week. Yeah, we've got that. Other things that we might be able to do: medication compliance, smoking cessation, alcohol reduction and cessation. We could all talk about as well. Responsive cardiovascular exercise. During exercise, increased oxygen consumption. There should be a linear increase in blood pressure. That means that as intensity of the exercise increases, the blood pressure increases in relation to that. No change in diastolic blood pressure. Within 10 millimeters of mercury is considered acceptable for diastolic. Increased respiratory rate and tidal volume. If we become conditioned, adaptions include increased VO2 max, improved extraction utilization. And when we see these initial change, the improved extraction and utilization improves far greater than just how much blood is pumped per beat. It's really about how the body uses that blood that gets conditioned and changes, improves over time. Increased plasma volume, improved skeletal muscle blood flow, reduced body mass and body fat, improved heat transfer, and then the improved psychological benefits: reduced anxiety, stress, depression, improved mood, improved self-esteem. That is the really great stuff. And I think if you've ever seen someone undergo some of these life changes where, and I'm sure you've seen it, Holly, where you work with somebody and after a period of time, like, just how they walk in a room is different. How they stand is different. We didn't work on posture, but because they dropped 30 pounds, they stand taller. Like, there's all sorts of things like that. So the improved psychological benefits is most of the time what our patients are looking for. Most of my patients don't say, Josh, I'd love to have some, my plasma volume is just too low, I feel. I'd love to, how do I get that better? My patients usually say, I want my wife to look at me while I walk by. Like that's usually what they're asking for. So a lot of the times it's the psychological benefits that what the patients are looking for. And I think we on the physical therapy side, we're looking for more of the physiological benefits, but both are great. Some safety considerations to modify or terminate exercise: increasing angina. What medication should be on hand if we have a patient who has a history of angina? Nitroglycerin. And what category is that in? Vasodilator. Good. Marked dyspnea, dizziness, lightheadedness, ataxia, cyanosis of pylori, excessive fatigue, or leg cramps or claudication. Other abnormal responses: failure for the systolic blood pressure to rise as intensity rises, so a blunted blood pressure response. Hypertensive blood pressure response. Decrease in systolic blood pressure. Change in systolic blood pressure, again, a change no greater than 10 millimeters of mercury would be the definition for that. Change in cardiac rhythm, or if ST or T wave segment changes in an EKG, if we have that on hand. Other things to make sure we're safe with: hot environments, take more rest breaks, risk of dehydration. So make sure that we're monitoring that. Be aware of signs and symptoms of heat stroke and heat exhaustion. Cold environments, colder can lower the angina threshold. So, we have to be aware of that. Also, inhalation of cold air may trigger asthma. Risk of frostbite or hypothermia. Higher risk for cold water immersion. I think or people with lower body fat. High altitude, greater than 5,000 feet, reduced partial pressure of oxygen in the atmosphere, leads to decreased arterial oxygen levels, and then we'll have compensations. So those compensations include increased respiratory rate, heart rate, decreased performance. There's acute mountain sickness, also a high altitude pulmonary edema that we could be aware of. Anybody ever do anything at altitude? Anybody ever go? Where were you when at altitude? Yeah. Mauna Kea.
Going Haleakala.
Yeah.
Going up just like steps.
Yeah. Isn't it amazing? So same thing with me in Hawaii, both in Haleakala and Mauna Kea. Yeah, my buddy, 30 feet away, someone was saying, so, hey, Joe, I got it. And I was running to him, and man, out of breath almost immediately, trying to jog just, from here to me to Tino. It was just like, holy cow, it is shocking. So in Rhode Island, highest point is, I think it's 810 feet. In Massachusetts, Mount Greylock, 3,500, just under 3,500 feet. And in all of New England, Mount Washington is 6,288 feet. So we don't have a lot of high elevations in New England, but that is something to consider. All right. Do we have any questions on anything else we covered today? So here's what we've got. I'm going to pull this up here. I did. Yeah, I tried to teach people how to do snow angels in Hawaii. It did not go well. There was a big cultural gap between the two of us, and yeah, that was a learning experience, that's for sure. Yeah, just lay in the sand and do it. Yeah.
Yeah, I
Yes.
grew up at 10,000 feet, so like, I never had an issue, but my wife who lived at sea level her whole life, and she moved to the mountains where I lived. She had the hardest time.
Yeah.
And I mean, I have climbed collegiate peaks, like 2,000.
Wow. Yeah.
And, I guess I never understood how somebody lived in sea level came to.
Yeah.
It was just that, like, it was really hard. Even me going back now, like, getting like 9,000 feet of top mountain.
Yep.
Right there. It was rough.
Yeah. Yeah.
Acclimating to
Right. Yeah, that's why the training adaptations at altitude, that's why elite athletes train at altitudes. Then when they come and compete at sea level, their body is compensated, have enriched myoglobin and all of that other stuff. So yeah, it's pretty incredible. So there are two cases that we do not have a ton of time for. 2:30, that's what we're going for. So let's have this half of the class do cardiac, that half of the class do case 1, which is COPD. I want you to read through the case, and at the bottom, there's got a few other questions. What tests would you like to either have done, or you can perform as part of the physical therapy treatment? What is your initial treatment? What is today's treatment? And then give a skeleton on what a 6-week program would look like. In the next 6 weeks, we're going to do these type of breathing exercises, these type of aerobic exercises. This educational component will be something we hit on. Just give me like categories. You don't have to map it out. And then the other one, we've got the same thing, except I'm also going to ask you, what is the likely diagnosis? Okay, so again, you have the cardiac one. You guys have the pulmonary one. So you guys have case 2. You guys have case 3. Let's spend just a half an hour looking at it, and then we'll quickly go through it at the end, okay? Oh, yeah, thank you. I was definitely going to forget. Thank you so much. In our textbook, and one of these cases, I think it's the first one. Oh, maybe I took it out. Thought it was in here. Anyway, oh no, here it is. 45 pack years. So smoking history for a pack year is how many packs per day times how many years were they doing it. So this person could have smoked 1 pack a day for 45 years, or they could have packed 3 packs a day for 15 years. Both would count as they would both add up to 45 pack years. So that's just a phrase of how many packs per day times how many years. Half a pack a day times 10 years, it's 5 pack years. So that's just one term and one calculation that I wanted to make sure we understood. That's a relatively newer way to describe how much have they been smoking. Okay, so that's what pack years are. Thank you so much. Also, for your cases, I want you to calculate that person's max heart rate using Tanaka formula. I also want you to calculate their target heart rate using the Carbonian method. I think so. Both cases have their resting heart rates in there. Okay, so use the I said 2 different ones. We just don't have enough time for it. Okay, it's in Blackboard. Yeah, I put it up this morning. It's in class practice cases, something like that. All right, let's quickly go through a couple of these. We'll start with the COPD one over there. You guys can feel free to glance at that. So just briefly, 67-year-old COPD exacerbation. She's had it for a few years. History of smoking, although she said she quit, on 2 liters of oxygen and some other medications. So what other tests would you like to see performed? Either medical tests or physical therapy data collection? That was you four were doing that part. Oh, blood pressure wasn't on there? Okay, yep. Yeah, no, I don't think it was. So blood pressure? Yep. Yeah, RPE at rest, but also with activity too, and what that activity is, yeah. I think instead of RPE, is there a different but similar one that we might be a little bit better for this person? Similar. Maybe the dyspnea scale might be, and again, I mean, they're so similar that, but yeah, I think maybe for this one, dyspnea scale might be a better choice than RPE. Maybe both of them we need, but yeah, it's a good one. Good thought. What else? Okay, so to figure out lung volumes and all that stuff, yeah, spirometry to figure out lung volumes. Yeah, that would be nice if, man, if we could have our every single patient doing that, that would help us. Yeah. Anything else? Those are the major ones that you got? Yeah, I think that's pretty good. I think there's also questionnaires. So there's a lot of different questionnaires. So if we go back to that pulmonary piece, there was, I think, 8 or so different questionnaires that we could give to our patient. That might be nice. I think the other thing that's missing here is some sort of endurance test of some kind. Whether, yeah, so in the physical therapy world, sit to stand, 2-minute step test, 6-minute or 2-minute walk test are the major ones that are easy to do. And I think exercise tolerance test, especially if we add VO2 max testing with it, that would be really, really nice. But I don't know, I don't think this person, if they're in the hospital, they're probably not saying, oh, by the way, let's do an exercise stress test. They're probably saying, get stabilize and get out. But some sort of endurance testing, if they haven't done it, then we should be doing it. Sit to stand test are an easy one, step test or walk test. What would the initial treatment look like? So an initial treatment is, I've got 30 to 45 minutes today. What are the number one things I can give to this person today? So what did you think this person today needs? Education on pursed lip breathing, you think is the important one, right? So they have COPD. COPD, we're trapping more and more air in. So pursed lip breathing gets more air out. I think that's a perfect tool to use. And we can teach them that not only in times of dyspnea can you use this, but just at rest we can do this as well. Good. What else? Education on oxygen safety. Great. What else? Yeah, and boy, that's a great point. Yeah, should we do that day one, or is this more of a day 2 or 3 thing? You know, again, you guys have all felt in your clinicals how fast that time goes. So good thought. Posture is going to be something that if we can't do it day 1, yeah, maybe day 2 we'll squeeze it in, but it's a really important one. Good thought. What else? You guys got anything else? I got 2 things I'm looking at that I'm hoping that you're gonna. Good. So more of the, our exercise program, again, maybe not initial visit, but will be to improve ambulation distance. And we know we can do 120 feet now. We're going to hopefully improve upon that with more walking. So the two things I'm looking at, auscultation, decreased breath sounds throughout lung fields, but especially at bases. So what do you think treatment-wise we would be able to do for that? You guys have any ideas? So decrease breath sounds throughout the lung fields, but especially at bases. What treatments could we do for that? I don't see any indication that we need postural drainage. If it was chronic bronchitis, then maybe. But here in the case we had, there was something about no sputum or something else like that, right? Or am I making that up? Oh, she had acute bacterial pneumonia, so maybe with auscultation, maybe we do need to do that. I don't see anything under auscultation. It should be like this section has crackles. That would definitely be it. I don't see that here. I just see decreased lung breath sounds. So what I'm thinking more for that is maybe segmental breathing, especially at these bases, to try to keep forcing air to that area. That's what I would think would be most appropriate for this. Yeah, I thought there was something about.
Oh, wait.
What was it? Yeah. Okay. All right. So no secretions noted. So that's so yeah, I'm thinking more segmental breathing rather than postural drainage. Although I think down the line things can change pretty frequently. So down the line we might need to add that. But for today, I don't think that's it. But segmental breathing I think could be more powerful. What about this note? Uses forward posture with arms supported on chairs to arms supported on chair, arms. Yeah, there's a typo there. Arms supported on chair to assist with accessory muscles of inspiration. Any treatment techniques that we should do today that you think? Say it louder. Diaphragmatic breathing. Yeah. So if we can encourage diaphragmatic breathing, we might be able to improve this ventilation and decrease use of the accessory muscles of inspiration. Good. 6-week treatment program. So we got a lot of stuff we got to do today. We talked about day 2. We might need to start working on posture if we don't have time day 1. So that's definitely going to be part of it. And then tell me more about your exercise program. So how are you going to get this person walking better than 120 feet? Okay, so we have to work on stairs as well as not only just the distance, but we also need to do stairs, which are more taxing. Yep, eventually. So that's coming. That's going to be in a few weeks. Yep. Did you guys go through your exercise prescription? Did you guys figure out what their max heart rate, target heart rate is based on the data we've got? So that's what we've got to do to figure out, okay, well, we're going to do exercise. We're going to do aerobic exercise. It's mostly going to consist of walking and stairs because that's the two actions that she needs to improve upon mostly. And we're going to do it within these parameters. So you got to calculate that based on the information you've got. You've got her age and you've got her resting heart rate. You can do that for that. Okay. That's the next step that you've got to do. Did you have something else, Steph? Oh, you did. Okay. So read off what's the high and low target heart rate for. And you used it with the Carvonian formula that you used, the more math one? Perfect. That's exactly what I was hoping you're going to do. Yeah. So all we have to say is we're going to do aerobic exercise. We're going to do as little as 10 minutes, but 20 minutes is the goal. So 20 of our 30 to 40 minutes is going to be aerobic exercise once we do these initial things. And it's going to be within those parameters, mostly walking and stairs. And then we could also use rating of perceived dyspnea or RPE scale to help us with that. But yeah, as far as heart rate goes, that's what it's going to be. And then next time she comes in, if her resting heart rate's different, we get to redo the formula for what that day is. Great job. All right, then you guys with the cardiac one, case 2, you guys can follow along. But 58-year-old went to the ER last night, shortness of breath, could not sleep flat. He had to sit up all night. He had an echocardiogram during his hospital stay, ejection fraction at 30%, has some medications, lives with his wife, 2-story home, likes some recreational activities. So what's the likely diagnosis with this one? 100%. Yeah, those 3 major things. The ejection fraction is the number one kind of concrete one, but having to sleep sitting up is the other big one. Yeah, so he's got an acute exacerbation of congestive heart failure, left-sided heart failure. Great. What other tests would we hope to see either from the medical side or that we can do? Great. Yeah, so some sort of endurance testing we can do in the physical therapy side, definitely. I think this is also a person we would have liked to see different from that, the breathing, the COPD case. I would hope that this person would get a exercise stress test of some kind in the hospital. Before you get discharged, we're going to do this exercise stress test. There's a few different ways they could have done it. Submax, symptom limited, probably symptom limited would make the most sense for this person, but I would have liked to see that from them. And then even with that, though, we still have to do our data collection. So even if they did an exercise stress test, that gives valuable information that we can formulate our exercise program around. But we still need to do our own physical therapy test. So I would have liked to see the medical side take a 6-minute walk test. I'm sorry, the exercise tolerance test, and then we get to do the 6-minute walk test, sit to stand test, or stepped, or something else along those lines. So great. What other data collection would you like to see? Yeah, so lung auscultation now and see if there's anything we have to do for that. Definitely. Yeah, that's a great thought.
Breathing, tree. Yeah,
Potentially spirometry. Yeah.
damn enough things.
Yeah, potentially the spirometry. I wonder if they wouldn't do it for him since it's a heart problem. But yeah, it could. We might. Yeah. Good. Anything else other PT wise that we need? I think you guys nailed most of them. Yeah. All right. Initial treatment. What do you think? Day 1. How are we going to help this guy? So upright is better, and we'll let the medication take care of what their job is. But yeah, probably staying away from especially feet elevated. That would overload the heart right away. Yep. Anything else for today's treatment? Yeah. At an ejection fraction of 30%, we have to start talking about activity pacing. Definitely. Yeah, there's only so much that we're going to do some exercise too, and it will hopefully improve endurance, but this left ventricle is not working well, and we are worried about this. And yeah, he needs some activity pacing today. He's going to need activity pacing the rest of his life because this 30%, that is not good. Yeah, great thought about activity pacing. That's probably the number one thing this guy needs to learn about. Anything else for day 1? Yep. Yeah, the same thing. Yeah. Perfect. Yeah. Activity pacing, endurance yeah, definitely. How about our like what does a 6-week program for this person look like? What other things? We can't just talk to the guy a bunch. Eventually, we got to do some exercise or some sort of treatment.
Low impact art.
Great. So some sort of aerobic exercise, rhythmic, large muscle groups, some sort of aerobic exercise. The mode, the exact mode of it, depending on what we want to work on. So keeping in mind the specificity of training, but also anything that's enjoyable. Yep. And when what parameters? So you said large muscle groups. What other parameters do we have that would help us determine the intensity of that? So doing the calculation now, this guy's resting heart rate was 140 beats per minute. So that's cooking. That's cooking at rest. But we can still do exercise. And the great thing about that Carbonian formula is for someone who has an elevated resting heart rate, well, if we're a foundation of exercises, we need to overload the body. We can't just sit there and say, your heart's working hard, just keep sitting there. No, if we're going to be doing, if he's safe enough to do exercise, we're going to do some exercise. We need to figure out how much can we tax his heart. We're going to use that Carbonian formula for, it's perfect for a person like this.
So you can get between.
So between 151 and 163 is this target heart rate zone that's safe to do? Yeah, so if he's at 140, we can get up to 153. What exercise do you think might elevate him to that? So getting dressed probably does. Yeah, I don't know if I would say, all right, take off your clothes and put it back on. I don't think that's a good PT session exercise.
It's not gonna affect the heart rate and stuff, so shouldn't we not base it off his heart rate and do like a heart rate or something?
You know, I skipped over which medications. Which medications are you looking at that would blunt the heart? Is he on any beta blockers? I skipped over that. I saw a diuretic. I see a statin. Digoxin. Yep. Yeah. So yeah, potentially we'd only be able to use RPE. Yeah, potentially. But we've got our resting heart rate of 140, so we can use that for now. That's just, again, paper patient. We do what we can. But yeah, so going from a resting of 140 up to 153, that just might mean standing might be it. That just standing alone. It might be simple marching just in place. That's probably enough. Maybe sitting at the edge of the bed doing some gentle arm exercises might be enough too, just to elevate them just a little bit. Good. Any other? I think that was what I was hoping for that. Any other elements to a 6-week training program? I think there's a lot of people that can use diaphragmatic breathing, and I think there's some clinicians that it doesn't matter what you're coming in for. I'm going to teach you diaphragmatic breathing first of all, and I think that's not wrong. It's not something I do. I do it for the patients who really need it. So I don't think you're ever wrong teaching someone diaphragmatic breathing. I don't know if in this case it would be crucial, but I think it's always good. Yeah. Anything else from you guys? I think basically, the pillars of this guy's treatment is education on activity pacing, education on ways to prevent the next acute exacerbation of this congestive heart failure. So staying away from salty foods and things like that. And then aerobic exercise to improve performance as much as we can. And within the heart rate ranges that we get to calculate on that day. That's pretty much the pillars of our exercise program. Does that make a lot of sense? Good. All right. Do we have any other questions on anything else we covered today? Yeah. It said decrease lung sounds throughout, but especially at the bases. So I thought if we could teach them segmental breathing just at those bases, then that might force air that way. That was my thought on the segmental breathing. And I think for that person, knowing that they've got COPD, that's probably a treatment technique that they're going to need in the future. So if we could teach them now then the next time they have an acute exacerbation, they already know how to do it. So that's one thing that I would probably add. I don't think there's an indication for postural drainage here. Now, if in the case it said something like crackles throughout, or crackles mostly at bases, then we say, okay, there's definitely still fluid in these lungs. Oh, it did? So now the positioning we've got to be extremely cautious with. Yeah, but so all right, so great point. So we had crackles in that case. I skipped over it, so I didn't even see that. So crackles in that case we'd want to address somehow, and especially on the first visit. I think that's a good first visit thing. But if we can't do postural drainage, and there's sometimes we can't do postural drainage percussion. We talked about it with osteoporosis, how we have to be really careful. What other things can we do? Active cycle of breathing. That would be a good one. What else? The huffing. Yeah. Yeah. Huffing techniques, huffing and coughing techniques. So I think active cycle of breathing and huffing and coughing techniques are probably it for this person. Better than postural drainage because again, we're worried about overloading the heart. And especially like, I'm not necessarily of, oh, this lobe of the lung, we need to get the fluid out and that's going to go to the heart. I'm not worried about that, but I am worried about if his legs are swollen, I put him in an upside down position. Now that is overloading the heart. So, all right. So active cycle of breathing with huffing and coughing techniques, great. Anything else that we could do? I'm thinking of a couple of devices. For $30, we could get some. The vest doesn't cost $30. Vest costs a handful of $100. The acapella and the flutter. So one of them have the breathe through the tube and it's got little metal balls that create that vibration. The other one has a little flap. The flutter has the flap. So we could grab one of those if we needed to. Yeah. So good thought. All right. So I think you guys did a great job with those cases. How did that feel working through those? Good enough? All right. So I'm going to stop this. Did I already stop it? No, I didn't. All right. Good luck studying.